Beginning with our first session, it's my honor to introduce the chairpersons for this session, Dr. Padmaja Raghavan. She's working as a consultant rheumatologist at Keracon. Dr. Sandeep Surendran, Assistant Professor, Department of Rheumatology, Amrita Institute of Medical Sciences, Kochi. Now, I would like to call upon our first speaker for the day, Dr. Adarsh MB, Assistant Professor in Rheumatology Department of Government Medical College, Calicut. He'll be speaking about stem cell therapy in osteoarthritis. I request the chairperson to introduce the speaker. Sir, please.
Evening to Keracon. So we'll start off with 8 topics, short topics. The first topic will be dealt by Dr. Adarsh. He's Assistant Professor in Rheumatology, Government Medical College, Calicut, and he'll be speaking on stem cell therapy in osteoarthritis.
A very good afternoon to all, and thank you, Chairperson and the organizing team, for giving me the opportunity. So I'll be talking on stem cell therapy in OA. So until recently, I thought that when we give stem cells, they will go to the cartilage niche, they will then proliferate, then differentiate. They form brand new chondrocytes and they form a smooth layer of cartilage. But it doesn't happen that way. And next to 10 slides, we'll see how it works. So stem cells are mainly of 2 types. The embryonic one, which are totipotent, they can form any cells, and the adult stem cells. Adult stem cells are of hematogenous stem cells, or adult stems can be mesenchymal stem cells. And the mesenchymal stem cells are the cells of interest in regenerative therapy in osteoarthritis. These mesenchymal stem cells can be harvested from the bone marrow. They can be harvested from the adipose tissue through liposuction and from the umbilical cord tissue. And they can form all 3 layers of the mesoderm, which include adipocytes, chondrocytes, and the osteoblast cells. So how does mesenchymal stem cells work in OA? For that, we need to have a glimpse of the pathogenesis of osteoarthritis. The cartilage is relatively avascular, relatively acellular. Only cells there are chondrocytes and their precursors. And the thing is, when there is an increased mechanical stress, which is beyond the reparatory capacity of the chondrocytes, the chondrocytes themselves shift into a more catabolic and activated chondrocyte phenotype. And these activated phenotypes, they secrete more metalloproteinases, they more reactive oxygen species, and instead of type 2 collagen, they secrete type 1 collagen, which is more a fibrotic one. And they also attract more immune cells to this. Within that immune milieu, there is an increased risk of chondrocyte getting into the catabolic or activated phenotype. And here comes the role of mesenchymal stem cells. So these mesenchymal stem cells have an anti-inflammatory and immunomodulatory function. They by secreting cytokines and anti-inflammatory cytokines like IL-10, also by their ability to have cell-to-cell interaction and inhibition of immune cells, they have an inflammatory effect and an immunomodulatory effect. They also have a paracrine effect, which is more trophic. They secrete growth factors, which helps in proliferation of the chondrocyte precursors, which are already there in the cartilage. They also have angiogenic effects by secreting angiogenic growth factors. And the mesenchymal stem cells per se can proliferate, they can differentiate into chondrocytes, and they can also contribute to the repair of the cartilage. So by anti-inflammatory effect and by trophic effects through paracrine effect, these mesenchymal stem cells work. So there are enough preclinical and clinical evidence to suggest that there is an immune role for mesenchymal stem cells. And also they have also shown that the cartilage, they reduce the degradatory products of cartilage. Also they have increased the synthetic the proteins of the cartilage. Also clinically, there are enough evidence to suggest that there is an improvement in the VAS pain score as well as the VAS stiffness score. And the cartilage quality is also improved after mesenchymal stem cells. Although the cartilage thickness or the cartilaginous volume was shown to not to improve, but at least they don't deteriorate when given mesenchymal stem cells. So how is the procedure? The mesenchymal stem cells, as I already told, are harvested from the bone marrow, the adipose tissue, or from the umbilical cord. They can be allogenous when they are harvested from the healthy donors. and autologous when it is harvested from the patient per se. The problem with the autologous is most of the osteoarthritis patients are elderly, so the basal fitness of the mesenchymal stem cells are not good. So it's the allogenous are a better option in that sense. But the problem with allogenous is there is at least a theoretical risk of immunogenicity and rejection with the allogenous mesenchymal stem cells, which doesn't happen that much. We can also, they can be injected intraarticularly, or we can give a target specific defect oriented implantation of mesenchymal stem cells using tissue glues, or we can use a scaffold where the mesenchymal stem cells can grow. There are no specific protocols which can be followed, but different studies have used different protocols per se, and they have used autologous and allogenous by them. And in addition to the stem cells, we can add adjuvants like hyaluronic acid or platelet rich plasma, or we can also add surgical procedures like high tibial osteotomy. Although they are not shown to have an improvement in the cartilaginous quality and thickness, but pain relief was better with when hyaluronic acid or plasma rich platelet rich plasma was used along with the stem cells. So how to select the best option? Patient selection is very important. KL grade 2 or 3 patients, moderate to severe intensity osteoarthritis are the ones who are benefited, and the inflammatory phenotype of the osteoarthritis are the ones where there is the maximum effect of stem cells. The MSC type, mesenchymal stem cell, whether bone marrow or adipose or umbilical cord derived, they doesn't make much difference. But if it is an autologous, adipose tissue mesenchymal stems are better than the bone marrow because they don't age as much. The bone marrow mesenchymal stems age. And you can auto versus allo, I already explained. Whether to go for a second injection after 6 months, it was shown that the cartilaginous quality and thickness better when a second injection was given after 6 months. But there is a theoretical risk of immunogenicity especially when we are using allogenous mesenchymal stem cells. Moderate to high dose of stem cells are to be used, which is around 40 to 50 million cells. And combination therapies with hyaluronic acid or PRP or surgical interventions can be considered while giving stem cells. There are few adverse effects, local pain and swelling, which are usually respond well, and theoretical risk of heterotopic ossification, because these mesenchymal stem cells can also go in for osteoblast, differentiate into osteoblast instead of chondrocytes. So there is a theoretical risk of heterotopic ossification per se. And what do the guidelines say on their use? The ACR says a big no for stem cell therapy at present. Okay, it's strongly against. And most other, including orthopedic associations, are also not so pro for mesenchymal stem cell therapy at present. They are either there is no evidence to suggest, or they are against the use of mesenchymal stem cells at present. And in the future directions, the main things which are being considered are to get the best mesenchymal stem cell, the mesenchymal stem cells which are the basal fitness of which are very good. So to have a better mesenchymal stem cell modifications are being planned, like using better culture medias, growing in hypoxic conditions. We can even use pulsed electromagnetic therapy or low level laser to prime the mesenchymal stem cells. And there is a new set of stem cells which are called induced pluripotent stem cells. We can use adult cells like a keratinocytes. Using adequate culture medias and growth factors, we can de-differentiate them back to a stem cells, and then they can differentiate them into a mesenchymal stem cells. These are being tried right now. And just selecting the extracellular vesicles, these are the secretion, the mesenchymal stem cells form extracellular vesicles, and by way of extracellular vesicles they function. So we can just engineer these extracellular vesicle along, and they can be given instead of the mesenchymal stem cells as a whole. So engineered mesenchymal stem cell derived extracellular vesicles are also being in the pathway. So it's the mesenchymal stem cells started just almost towards the end of 1990s. So it's only 20 years since the introduction, and it is a rapidly evolving one. Although the guidelines are so much against mesenchymal stem cells right now, but in the near future, with better therapies and with better stem cell retrieval methods and culture methods, we can expect maybe next or next to next ACR going pro for mesenchymal stem cell therapy. So to conclude, MSC act through local immunomodulation. They have a trophic effect with chondroprotection, cartilage repair, antifibrotic and anti-angiogenic effect. Patient selection is and selecting the stem cells which are basally fit are important for the better outcome. Currently, there are no recommendations to suggest which type of stem cell, what dose, whether to use combination or not. But at least from the literature, there is uh, the medium to high dose allow better than auto, and repeated a second injection after 6 months better than single seems a better option. Currently, it's a pain relief and a bridge till total knee replacement, and all the guidelines do not recommend stem cells in osteoarthritis right now. Thank you.
Dr. Adarsh was a precise talk, well completed in time. As we have other topics, we'll take 1 or 2 questions.
Adarsh, it was a great talk and a great start to the Keracon 2024. Adjuvant, you said PRP can be used and hyaluronic acid can be used. Can the steroid be used? All the studies with the mesenchymal cell therapy suggest that the pain improvement is not that much. So if you are looking at the structural modification with MSC, steroid will provide some type of pain relief in the beginning. What do you think?
Sir, none of the studies which were quoted were using steroid as an adjuvant. They have used hyaluronic acid. Steroid per se has an anti-inflammatory and modifying effect. So that may be the reason. Whether that will inhibit the action of mesenchymal stem cells per se is not known. And none of the studies have used as such steroid. They have used PRP. Even one study used weekly PRP and weekly hyaluronic acid for 4 weeks after the mesenchymal stem cells. Just they have shown some improvement in pain, but not for otherwise not for. But almost all studies have a recorded time of only 40 up to maximum 48 weeks. So we know cartilage growth is a very slow process to have. So sometimes it may take some more time to recognize its effects.
Thank you. There are no more questions. We can move on to the next talk.
Thank you.
Thank you, sir, for the thought-provoking session and the wealth of knowledge you imparted. Our next speaker for the day is Dr. Srinath S., consultant rheumatologist at St. Gregorius Medical Mission Hospital, Parimala. He'll be talking on herpes zoster vaccination in adults with rheumatic diseases. I request the chairperson to introduce the speaker.
I'm sure Srinath needs no introduction to this crowd. So I invite him to start his talk.
Good evening to all. First of all, I would like to thank my sincere gratitude to the organizers of this conference for granting me this privilege to address this esteemed gathering of medical professionals here. I will jump straight into my topic. I would like to start with this quote. With the exception of safe water, no other modality, not even antibiotics, has had such a major effect on mortality reduction and population growth. That was the impact of vaccines in overall health of the world population. So, as we all know, varicella zoster virus, which causes chickenpox, it will remain dormant in the nervous ganglia for many years before reactivation. During periods of stress or immunosuppression, it will travel down the sensory neurons, leading to a painful blistering rash, what is called herpes zoster. The pain that is experienced in herpes zoster is supposed to be, according to the McGill Pain Index, it is considered to be one of the highest top 5 pain that a human can suffer in his lifetime. It is due to the necrosis of nerve cell bodies. It can also lead on to Bell's palsy, herpes zoster oticus, and it can affect ophthalmic nerve, leading to herpes zoster ophthalmicus, retinal necrosis. It can cause CNS complications like meningitis and encephalitis. So, what is the risk of developing herpes zoster in general population? It is believed that around 90 to 95% of the world population has been exposed to varicella zoster over the last 3 or 4 decades. So in the general population, the reactivation risk is approximately 1 in 3, 25 to 30%. As the age increases, for those who are above 80 years, the risk increases to 1 in 2. So that is going to be the one major health hazard or problem, public health problem India is going to face. Why? Because by 2050, 15.8% of Indian population is going to be above 65. So that is why now it's the time we have to act. What does the literature say about the risk of herpes zoster in autoimmune systemic rheumatological diseases? This is the systemic literature review of 2019 EULAR guidelines for vaccination. It says the risk of herpes zoster infection is very high. The pooled incidence rate ratio is 2.9 in patients with ARDs. It also shows an increased risk of 2x increased risk in rheumatoid arthritis and a 4 times increased risk in SLE. There have also been other population-based cohort studies where they found an hazard ratio of 3.9 in inflammatory myositis and a hazard ratio of 1.69 in Sjogren's syndrome. So definitely, it appears in systemic autoimmune rheumatological diseases there is an increased risk of herpes zoster. But most of our patients, especially adult rheumatological patients, they are on some kind of immunomodulator therapy. So does it actually further increase the risk? So there have been various studies showing glucocorticoids definitely increases the risk of herpes zoster in a dose dependent manner. But with other medications like methotrexate, even though there are studies, no clear association has been found between use of methotrexate and increased risk of herpes zoster. Regarding TNF inhibitors, there have been few studies which shows an increased risk, but there are some other studies which showed no clear association. So the data here is quite inconclusive, to be frank. But for JAK inhibitors, they have the maximum evidence. The use of tofacitinib has shown to increase the risk of herpes zoster by about 2 times. There are various studies. So this is the data from German Rabbit Registry. We studied more than 12,000 patients. It showed that the crude incidence rate is 2.5. If you see the graph, it is much higher than any other immunomodulator therapy. So definitely in autoimmune rheumatological diseases, the risk is high. Especially with glucocorticoids and JAK inhibitors, the risk is very high. So what is the solution we have? We have the zoster vaccine. So that is our topic today. So zoster vaccine, earlier it used to be Zostavax, that is a live attenuated zoster vaccine, which had an approximate efficacy of 50 to 65%, slowly being phased out from all parts of the world. It was discontinued in US in August 2020. And now we have the recombinant adjuvanted zoster vaccine, Shingrix. It is nowadays preferred over Zostavax. It shows superior immunogenicity and clinical efficacy. On comparison studies, it has an efficacy of more than 90% compared to Zostavax in both against shingles as well as to post-herpetic neuralgia. So how is it given? So it is, as I already said, it is a recombinant adjuvanted vaccine. It comes in 2 vials. One will contain the antigen, the other will contain the adjuvant. You have to reconstitute it and give it as an intramuscular injection. Usually recombinant vaccines are given as subcutaneous, but like in the Cervarix vaccine, here it is an intramuscular recombinant vaccine, preferably to be given in the deltoid. After taking the first dose, the second dose can be considered approximately between 2 to 6 months after the first dose. The antigen here is the glycoprotein E, recombinant glycoprotein E, part of transmembrane domain of the herpes zoster virus. The adjuvant is AS01B. It has various components. It is the adjuvant here that induces a local inflammatory response and enhances the T cell as well as antibody response against the zoster virus. These were the pivotal trials. ISADOE 50 and 70 were the trials which showed in all age categories the efficacy has been above 90%. So we found that there is an increased risk in rheumatology patients. The vaccine appears to be efficacious. Is it really safe? That is what we want to know. Is it really safe to recommend it to our patients? How safe is the vaccine? There have been numerous adverse reactions which were found in ISADOE 50 and 70. Most of them were pain at the injection site, myalgias, fatigue, headache and all. Even though the overall numbers seem to be rather high, severe reactions were actually very less. And most of them were not long lasting, with a median duration of just 2 to 3 days only. In the safety in rheumatological diseases per se have not been studied much. The evidence is scarce since the vaccine was available only for past 5 to 6 years. But generally, the adverse reactions are mild. Disease flares are very infrequent. Efficacy appears to be same as in general population. But recently in March 2021, FDA issued a black box warning against incidence of Guillain-Barré syndrome. But still the benefits, they reaffirms that the benefits outweigh the risk. There have been various incidences of vaccine induced zoster from various parts of India. These are images which were shared by our colleagues from northern part of India. These are 3 cases of vaccine induced infections all within the first week of Shingrix vaccine, and 2 of them were on steroids and tacrolimus, one was on tofacitinib. So this is something we need to keep in mind. So whom to give these vaccines? Vaccine currently is approved in 51 countries. 26 national recommendations actually is pro for this vaccine. But in India, currently it is approved only for those who are above 50. But still there has been many expert consensus group meetings which are in favor of using this vaccine for those who are less than 50, especially for young adults at risk, our patients, young adults who are suffering from immunosuppressive conditions. So what does the ACR say? 2022 guidelines definitely strongly recommend taking herpes zoster vaccination. The 2019 EULAR update also strongly recommends a herpes zoster vaccination. So when to give generally? Ideally 2 doses, as I said, 2 to 6 months apart. Preferably, ideally, optimally it should be given in a state of well-controlled autoimmune disease, but not in a state of disease flare. If at all possible, give it prior to initiation of immunosuppressives. If that is not okay, give it when the immunosuppression is rather low. 2022 ACR guidelines also says if the patient is on prednisolone more than 20 milligram, defer the vaccine, wait until you can reduce the glucocorticoid dose to less than 20 milligram. For rituximab, what you need to do is, if possible, give it before initiating rituximab, or if it is not possible, plan it before the next dose is due, and make sure 2 to 4 weeks are elapsed after the vaccine before the rituximab dose is given. For methotrexate and other immunomodulators, they all recommend to continue the medicines as such. So what will you do in these cases? A 59-year-old female with rheumatoid arthritis, low disease activity on methotrexate. She had a herpes zoster reactivation, but it was in the distant past. So what would you be doing? Would you think the patient already had herpes zoster, she is immune to it, so is there no need to give it, or should you give the vaccine? Actually, in general population, the reactivation, the recurrent herpes zoster risk is only 1 to 5%. But here the issue is the patient has multiple risk factors. The age, the comorbidity, diabetes, long-standing disease, she is on methotrexate and glucocorticoid, so she is someone with very high risk of reactivation of disease or recurrent herpes. So you should offer the vaccine. But if she had it in the recent past, same patient, what can you do? You can consider it to be given at a later date. You need not be rushing for giving her the vaccine. For the same patient, if you are planning to give other vaccines also, is it okay? Yes, it is. You can co-administer with other vaccine. Co-administration with influenza, PPSV and TDAP has been studied. No interference with immune response, no major safety concerns, but use at an anatomically different site. So what if there is a reactogenicity to the vaccine? Before vaccine, counsel the patient adequately, use antipyretics or analgesics. If it is a non-serious reaction, they all recommend to continue with the next dose. But if it is an anaphylaxis, never. Don't give the next dose. Last slide. In pregnancy, there is no recommendation for use. For breastfeeding, there is no risk found. So you can consider giving it without regarding the breastfeeding status. For any acute illness with or without fever, or maybe an acute current episode of herpes, wait till the current symptoms completely subside and then plan the herpes zoster dose. So what we have learned is we have a substantially elevated risk of herpes in systemic autoimmune rheumatological disease, more with SLE, more with glucocorticoids, more with JAK inhibitors. Shingrix has evidence to be more efficacious and safer than previous vaccine. Evidence is very low in systemic diseases, but you need more studies. Still, benefits are found to be more than risk. So, in SARDs, vaccine is strongly recommended. So, my final word will be to get everyone vaccinated. Thank you. Sorry that it was a little bit fast.
Excellent talk, Srinath.
Thank you.
Love the graphics and the images. Very pretty. I'd like to open the for questions. Anyway.
It has to be me again.
Sir.
I think you might have said it, but people who I intend to use tofacitinib, if they had herpes zoster before, the question came up, would you give them vaccination and then put them on tofacitinib?
If the disease activity permits, yes. The ACIP recommendations from US actually says there is no need to screen for or ask for any previous history of herpes at all. It is not found to be actually cost effective, and it rather impairs the vaccination rate as well. So since patient is going to be on tofacitinib, there is definitely a risk of recurrent herpes. Patient also has an autoimmune disease, so better vaccinate the patient if possible before tofacitinib. But if it is not possible, start her on the drug, counsel the patient, wait for the disease activity to get better, and then try to vaccinate them. Definitely, it will be recommended.
So 2 doses required, and if the patient developing the infection in between that, what will you do?
No problem. So it is advised to continue but we have to wait until the acute symptoms completely subside. You can continue with it, continue with the vaccination series.
Two doses.
2 doses is enough. But if you really think, if you can't wait for that long for some reason, logistical reason, if you take the first dose and then take the second dose by around 4 or 6 weeks, if it is little early, then you should also reconsider getting another dose after considering the risk and disease activity. You can give them, because the vaccine efficacy may be subclinical. So you can counsel them and advise another dose later. If it get delayed more than 6 months, what to do? There is no indication for restarting the same series. You can continue giving the second dose and leave it off. That's it.
Thank you for your questions. Thank you, Srinath. We'll move on to the next talk.
Thank you, sir, for the valuable insights shared. Moving on to the next session, I would like to call upon Dr. S. Anu, consultant rheumatologist, Keracon. She will be talking about muscle imaging in idiopathic inflammatory myopathy. I request our chairperson to introduce the speaker.
I think we already introduced the speaker, so I need not introduce. Moving on to Dr. Anu.
Thank you, the organizing team, for this wonderful opportunity. Thank you, chairpersons. My topic for today is muscle imaging in idiopathic inflammatory myopathies. I'd like to begin with a case scenario of a 35-year-old lady who comes to our rheumatology clinic with painless proximal weakness involving the upper and lower limb muscles for the last 1 year, insidiously onset, gradually progressive. So, on examination, the power in the upper and lower limb proximal group of muscles is grade 2 and her CPK is elevated at 840. With a strong clinical suspicion of polymyositis, we did the autoimmune evaluation. Here, the myositis profile came out to be negative. So, what next? She is a suspected case of polymyositis. So, her age is fitting, there is muscle weakness, there are no skin manifestations or autoantibodies. Next, what would you consider? Muscle biopsy is the one which is given in the ACR-RUDA 2017 classification criteria to consider if she fits to myositis. So, we all agree to the fact that muscle biopsy is a gold standard investigatory modality for inflammatory myositis. But it is an invasive procedure. Hence comes the role of muscle imaging. The various imaging modalities available are MRI, PET-CT, and ultrasound. So, let us first have a brief discussion about MRI and then very briefly about the other two imaging modalities. Coming to the role of MRI in myositis, it helps us in determining the type of abnormalities in the muscle, namely inflammation and damage. It supports a diagnosis. The sensitivity and specificity of muscle MRI as per various studies were almost very good, 80 to 100% and 70 to 90% respectively. It also helps us to guide muscle biopsy. And not only that, it helps us in following up of a case of inflammatory myositis. It not only does demonstrate inflammation in the muscle, but also in the layer of skin, soft tissue, etc. It also helps us to evaluate or exclude any concomitant pathology. So this was a retrospective study data, a scatter plot, which shows that there was a positive correlation between muscle edema score and histopathological inflammation. So muscle edema was scored based on MRI and histopathological scoring was done semi-quantitatively, and the muscle edema positively correlated with histopathological inflammation and muscle atrophy negatively correlated with histopathological inflammation. So MRI almost correlates with biopsy. In another study, it was shown that biopsy from an MRI affected muscle where there was muscle edema showed more inflammatory cells than biopsy from MRI non-affected muscle. Again, favoring the fact that muscle biopsy and MRI correlates. Not only that, MRI muscle edema score was also found to correlate with muscle enzymes, MMT8 score, and PGA score. Hence, can we really replace MRI, muscle biopsy with an MRI? Well, we usually use it as a screening or triage tool or an add-on tool to muscle biopsy, not really replacement of muscle biopsy, because there are a lot of mimics of myositis we know which has to be ruled out through muscle biopsy. Especially in early cases when there is only fasciitis, that is inflammation of the facial layer between the muscles, and in cases where the muscle enzymes are normal, then MRI will be of great clinical aid to the rheumatologist. So the role of MRI is invaluable. After MRI, knowing this much, we have to know whether we have to do a whole body MRI or a restricted whole body MRI only limiting to the thigh and gluteal region. Well, this was a study which showed that the imaging time was 33% shorter when the imaging was restricted only to the thigh and gluteal region, and the sensitivity and specificity for muscle edema and fatty atrophy detection for whole body versus restricted whole body were comparable. But there are certain specific situations like JDM, IMNM, and mimics of myositis where we need to really subject the patient for a whole body MRI. It would be prudent to know this pattern of muscle involvement in imaging. So, in almost all types of myositis, as can be seen from this table, there is symmetric involvement of proximal group of muscles of upper and lower limb. But in IBM, there is a specific pattern like distal predominant involvement, distal quadriceps, sartorius, medial gastrocnemius in case of edema, and in case of atrophy, FDP muscle involvement are all characteristic. And in JDM, there is more chance of involvement of abdominal muscles, paraspinal muscles, in IMNM as well. So in these cases, and when we suspect mimics of myositis, it would be prudent to take up a whole body rather than a thigh and gluteal region restricted imaging. After knowing that, whether do we need to subject contrast-enhanced, gadolinium contrast-enhanced imaging versus non-enhanced imaging? Based on various studies, it was shown that there was no much difference, statistically significant differences between contrast-enhanced versus non-enhanced MRI. So we understood that if we suspect a case of myositis, we can restrict ourselves to MRI imaging of thigh and gluteal region, non-enhanced imaging. Now we are rheumatologists, we have forgotten the basics of radiology. Let us quickly brush up. So going to the basics, so we have the T1 weighted sequence, T2 weighted sequence, and a fluid sensitive fat suppressed imaging, most commonly used being the STIR sequence. This is how the muscle normally will look in various sequences. So T1 weighted imaging, as we can see, the fluid is hypointense, the fat is hyperintense, and the muscle is grayish in intensity, intermediate between both. Whereas T2 weighted, fluid and fat both will appear hyperintense and muscle is grayish, lower than both the intensities. And in STIR sequence, the fluid is enhanced, the fat is suppressed, and the muscle will be again gray, intermediate between both. So what we can observe is that the STIR sequence or the short-toe inversion recovery sequence modified T2 is actually an inversion image of the T1 weighted imaging. So after knowing this much, let us go into the patient's MRI images. So this was a coronal T1 weighted imaging. We can see subcutaneous fat is hyperintense. This is a T1 weighted image, and this is a gluteus maximus. And we can actually see that there are hyperintense lines, which is actually fatty infiltration, which is a chronic change, and the muscle was also found to be atrophied. Thickness was found to be lower than normal. So going to the T2 weighted imaging, axial cut of the thigh of the same patient, we can observe that there is hyperintensity in the subcutaneous plane and also in various muscle groups in the anterior and few of the posterior compartment. So this hyperintensity could be either fat or fluid. So in order to understand, we proceeded to the STIR sequence, where it is clearly seen that the muscle layer is having hyperintensity and the fat has been suppressed in this sequencing. So this patient has muscle edema and as well as atrophy or fatty change. So muscle edema, as we know, indicates activity, and muscle atrophy or fatty change demonstrates damage. So by now it is clear that we have to take a bare minimum axial and coronal T1 weighted and STIR sequence in order to really look for the changes of myositis in an MRI. So there is another caveat behind it. Muscle edema in MRI is not always equivalent to myositis. There are various other causes like denervation, infectious myositis, rhabdomyolysis, trauma, delayed onset muscle soreness, radiation therapy, compartment syndrome, diabetic muscle infarction, to name a few. Finally, after getting guidance from the radiologist, we proceeded to the muscle biopsy of vastus lateralis, and there was a classic change of polymyositis where there was endomysial inflammatory infiltrate without any perivascular atrophy or any changes of necrosis. So the diagnosis of polymyositis was made, but her autoantibody was negative. She was treated with the glucocorticoid and mycophenolate, and she gradually showed improvement. And at the end of 3 months, the muscle power improved to 4 minus in the proximal group of muscles, but the CPK was still high at 450. Now, at this point of time, do we need to really repeat an imaging is the next question. In various studies, it was proven that there is a delay of 2 to 5 months for MRI normalization or changes in MRI with initiation of treatment. So the reasons proposed were subclinical inflammation, delayed clearance of inflammatory cells, etc. Now, in an European Neuromuscular Conference workshop, these were the indications proposed for follow-up imaging in a case of myositis. Whenever there is poor treatment response, whenever there is disease relapse, or whenever there is diagnostic uncertainty, we might need to do a follow-up imaging. So, going to the monitoring and follow-up, another important tool which we have is quantitative MRI. It is an objective, precise method of quantitating the activity as well as damage in myositis. There are semi-quantitative as well as quantitative methods, of details of which I am not going into. It's also helped by computer-based analysis, and artificial intelligence is coming in a big way here. We can actually quantitate how much fat fraction, how much edema portion each muscular group is having. Going to ultrasound, it's a real-time, dynamic, expertise-dependent imaging. It's a bedside imaging tool we are all aware about. The sensitivity is around 60 to 80%, specificity is around 50 to 70%. In active myositis, the muscle will appear as hypoechoic. The normal muscle echoes is comparable to that of subcutaneous tissue, whereas in chronic case, there will be fibrosis and fatty replacement, which will lead to increased sound wave conductance, hence hyperintensity in ultrasound. So it was shown that muscle echo intensity correlates with creatine kinase values, MMT8 scores, inflammatory T cells, MRI scores, etc. And in early cases, the power Doppler signals in ultrasound was helpful to diagnose early myositis and fasciitis. So this is a HECMAT semi-quantitative scoring system, which was actually found to correlate or detect changes as early as 9 weeks in a study using monotherapy with IVIG in a case of myositis. It also helps in detecting calcinosis and helps us to guide muscle biopsy. So this is a better tool rather than MRI in following up of a case of myositis because it's sensitive to earlier changes as early as 9 weeks according to the study. Going to PET-CT, as we are all aware, it's a nuclear medicine imaging modality with a varying sensitivity as per various studies, 33 to 90%. Specificity is quite high, 75 to 100%. We can combine it with CT or MRI. With MRI, the sensitivity is higher. It gives metabolic information about the activity of myositis. With dermatomyositis and other types, FDG is a tracer, but when we suspect conditions like inclusion body myositis, we use tracers like PIB and florbetaper. The added advantage of an FDG PET is to detect extramuscular inflammation, namely ILD, arthritis, and also as a screening tool for malignancy. Thank you.
Very good talk, Dr. Anu. Any questions? Only Dr. Vinod is asking.
I'm rapidly reaching my annual quota of asking questions from the floor. So, so you said 39. So if we use the conventional MRI, it will take 39.
57 minutes if the whole body imaging is done, and 37 minutes if we are doing. That was average time as per that study.
So suppose I go for conventional MRI. What are the chances of me missing true polymyositis if I use only the thigh?
Okay, in cases where we suspect inclusion body myositis and JDM, there may be more chance that we may miss the characteristic findings because the findings may be focused on the paraspinal or abdominal muscles alone. And in JDM, in early cases, there may be only fasciitis restricted to certain group of muscles which might not be picked up. But in all other cases like dermatomyositis, polymyositis, and overlap myositis, the imaging of thigh and gluteal region is sufficient as per studies in comparison to whole body imaging.
So, Sisam.
I'm honestly not aware of there being a recommendation to do whole body muscle imaging in JDM actually.
Yes,
it's I mean, just today our review has been published on idiopathic inflammatory myositis, and we went through all the literature. There is, I mean, uh, unless you think that you might be dealing with something else, there's really, I'm not aware of any recommendation that we need to do whole
Yes,
body
ma'am.
imaging, and MRI thigh
Is
suffices.
sufficient.
Unless on examination you think that another region is more significantly involved compared to the pelvic girdle, then you might think. But I've never so far needed to do any other imaging other than MRI thigh.
Thank you, ma'am. In that European Neuromuscular Conference workshop, these was the indication they have proposed. Like if you are suspecting these particular conditions, you might have to do a whole body.
Okay, thank you, Dr. Anu. Moving on to the next topic.
Next session will be on single cell sequencing and its clinical applications in rheumatic diseases by Dr. Abida Aliyar, consultant rheumatologist, KIMS Trivandrum.
I'd like to welcome Dr. Abita on the stage.
Good evening, everyone, and thank you, organizers, for this great opportunity. So, my topic today is single cell sequencing, clinical applications in rheumatic diseases. So, the agenda would be introduction and regarding omics and single cell analysis, what and why, and single cell RNA sequencing, the procedure, and single cell sequencing, clinical applications in rheumatology. So this topic being an evolving and a new in the field of medicine, I just to set the context and bring the basics. So zoologist William Thorpe said the most elementary type of cell constitute a mechanism unimaginably more complex than any machine had thought of, let alone constructed by man. So we started with the single cell zygote and we went studying to multicellular. Again, we are back to the single cell now. So we know this core concept because the interaction between the genome and an exposome determines the health and the disease. So, so after studying the disease, we now know that we have to study like the Hippocrates said, it's far more important to know what the person the disease has than what disease the person has. So we have come to the personalized medicine today. So traditional medicine, it started with the anecdotal evidence and treating the patients who exhibit the symptoms. Currently, we are in the era of evidence-based medicine and moving to the precision medicine. So precision medicine and the personalized medicine, currently the 5P medicine. So 5P medicine approach, which consists of preventive, predictive, precision, participatory, and the personalized approach. So for what are the building blocks for these precision medicines? So we need clinical data, we need omics, we need imaging and digital tools. And let me go on describing what omics is, because it forms the most important building block. So omics aims at the collective characterization and quantification of wholes of biological molecules that translate into the structure, function, and dynamics of an organism or organisms. So this started with the genome, the Breakthrough Human Genome Project. So we can broadly divide it into two types, technology-based omics and knowledge-based omics. So technology-based omics, the big four omics are genomics, transcriptomics, proteomics, and metabolomics, out of which, we have the epiomics and interactomics, and out of which genomics and transcriptomics are studied with the help of sequencing, and proteomics and metabolomics, we use mass spectrophotometry to study more on that. And we also have knowledge-based omics, where these data from the big four omics are integrated and studied taking in separate knowledge domains like immunology or microbiology. So after studying the main four omics, we translate these big data and with the help of bioinformatics, we code it down, including taking the help from machine learning AI approaches. And we can now describe the patient phenotype with these big data. So especially in our autoimmune rheumatic diseases, which has got significant patient heterogeneity. And this can be utilized for the 5P approach, personalized medicine care, as I explained before. So now what is single cell analysis? So, single cell analysis refers to technologies used so as to obtain genomic, transcriptomic, or other multiomics information at single cell level. So, we now know that so we have accomplished human genome projects. So, that, that being accomplished, and we know, then why to study the single cell? Because what we have done with the human genome project. So, so that was actually bulk sequencing, where we were studying cell population, not a single cell. So we know that human body consists of 37 trillion cells, and each cell is heterogeneous. So here, coming to the bulk sequencing. So bulk sequencing examines the genome of a cell's population, such as a cell culture, and its output is the average genome of the cell population, as shown here. And here, this is the single point. So this is the heterogeneous tissue here, and we are so here we have the heterogeneous tissue, and we are isolating the single cell barcoded cDNA of each tissue and sequencing it. And finally, we can see here. So this was the bulk sequencing, where we got an average expression of the cells, and the bulk expression data showed equal expression by all the cells. But here you can see the A and C being showing an expression of the cells, and the B cluster is not showing similar expression. So there is changes within the heterogeneous tissue between the cells. So single cell sequencing is but more expensive, labor intensive, and gives detailed information of the individual cells, reveals cellular heterogeneity and subpopulation expression, and it's more complex compared to bulk sequencing. So what are the applications of single cell sequencing? So you can study all the complex biological systems, especially embryology, oncology, where it is being more used, and evolution tissue, and immunology, where our rheumatic diseases also come. So now, after the Human Genome Project and various other projects of multiomics, we are in a process of human cell atlas. We are mapping the human cell atlas, where Human Genome Project was like Book of Life, the human cell atlas and hub map. This is biomolecular atlas that is going to read how each cell in the body is going to read this book. So coming to single cell analysis in rheumatology, you can study the normal tissue homeostasis and perturbations in those that lead to these pathogenesis of these complex immune diseases. So both genetic and epigenetic expressions, heterogeneous and new cell types and molecular pathways, and functional status. So leading us to understand more of the pathogenesis of our diseases, because it has got greater heterogeneity, and helps in identifying novel and therapeutic targets, specific predictors of treatment responses, thus helping in precision medicine, and thus mitigating treatment resistance and failures. So we already have collaborative projects like the Accelerating Medicines Partnership, RASLE network, which was established for single cell studies in rheumatology. So now coming into the procedure per se. So you can study any of these omics at the cellular level, as we have studied it in the cell population level, and we have already come out with all projects. So here in genome, we'll be studying structural variations, haplotype, copy number variations, SNPs. And in epigenome, we have the transcription factor binding, histone modifications, chromatin changes, and DNA methylation changes. And in transcriptomes, full-length intertranscripts, alternative splicings, and gene allelic specific expressions. So you can see that these, our diseases generally does not involve so much of genomic changes. We are more, our diseases show more of transcriptomic changes. And so coming into the methods to study all these. So single cell genome sequencing can be studied with various methodologies, and these are based on whole genome amplifications. And likewise, we have for epigenome, so various methodologies to study each of these changes. And transcriptomics, we have various methodologies like this. And we can study all these together with multi-layered omics sequencings, where along with the spatial information, because the tissue architecture, even God has designed it like that. The spatial arrangement between the cells is also important. That also has role to play in disease phenotypes. So coming to the single cell RNA sequencing, this is the most studied technique in rheumatology, where we have to first isolate the tissue and into the suspension of single cells, after which we isolate and capture these single cells via traditional methods and via microfluidic systems. Microfluidic systems have these oil in the running phase, and we have gel beads which are barcoded. So these barcoding is unique for each cell, and then the further downstream reactions will take place inside these micro droplets, or a micro well based system is also there. And after cell lysis and reverse transcription cDNA synthesis, we sequence the library, and finally, with the help of bioinformatics, we analyze the data. So coming to clinical applications in rheumatology, first study was done in 2017. They analyzed the peripheral blood cells, skin, kidney disease from patients with lupus nephritis, and they found an increase in interferon-stimulated genes in each tissue. In 2018, RA and systemic sclerosis tissue was also sequenced. So coming to pivotal discoveries made in rheumatoid arthritis, they have found that CD34 minus THY1 plus fibroblast in RA synovium, that is pathogenic and can be a potential therapeutic target. And likewise, here, pathogenic fibroblast, there was IL-1 beta inhibition, Notch inhibition, and EGFR inhibition, FGFR1 inhibition can be potential therapeutic targets. In coming to SLE, there was upregulation of, just two more slides, upregulation of interferon stimulated genes in almost all of the tissues in the SLE. And you can use the urinary IL-617 as a biomarker in lupus nephritis treatment response. And in systemic sclerosis, again, various potential fibroblasts. So you can use these as the targets for further drugs. So take-home points is, so single-cell RNA technology, the most commonly studied, has a crucial role to play in precision medicine. And as more and more we study about single-cell technology, it's becoming more complex. References and okay. Thank you.
Thank you. It was very detailed talk, I know, as you had to rush through in the end.
Okay.
But if anyone has any questions. Do you think with anifrolumab coming for SLE, this might be a way to target patients in whom
Anifrolumab, sir?
coming in SLE at some point? Do you think this might help us target which patients
Yes,
will
yes,
benefit?
yes, definitely.
I think that would be one way
Yeah,
to
yeah,
go
yeah.
about it.
Yeah, yes.
If no more questions, I'd like to close this session. Thank you.
Thank you.
Thank you, ma'am, for delivering such a rich and informative presentation. Next session will be by Dr. Anjana G. Warrior. She will be speaking on the topic tyrosine kinase 2 as a therapeutic target. I kindly request our chairperson to introduce the speaker.
Welcome, Dr. Anjana. She's a consultant rheumatologist at IRIS Trivandrum. Over to you.
Good evening, all. At the outset, I'd like to thank the organizers for giving me the opportunity onto the topic TYK2 as therapeutic target in autoimmune diseases. So, cytokines have a critical role in pathogens of several inflammatory and autoimmune diseases. The biological therapies which target extracellular cytokines have drastically improved the treatment of these diseases, but still they have not been entirely successful, with a substantial portion of patients not achieving long-term remission. Also, most of these biologicals are injections, which affects the long-term compliance of patients, and thus there is a need for oral targeted therapies, oral targeted therapies which targets the intracellular signaling. And there came the JAK inhibitors. JAK inhibitors inhibit Janus kinase, which are intracellular kinases which mediate downstream signaling pathway of type 1 and type 2 cytokines. So, this is in a nutshell about the JAK-STAT pathway, a cytokine on combining with the cytokine receptor on the membrane cause a conformational change which lead to dimerization of JAK, which leads to dimerization of STAT, and these STATs, dimerized STAT, translocates to the nucleus, leading to gene transcription and protein translation. So there are the Janus kinase family consists of 4 members: JAK1, JAK2, JAK3, as well as TYK2, and the STAT has 7 members, a combination of cytokines. These 4 JAK and these 7 STATs lead to various effects. So how do the JAK inhibitors? So when they inhibit JAK, they are indirectly inhibiting the effect of the concerned cytokine. So these are the type 1 and type 2 cytokines producing their effect through various JAK and STAT. So what is the problem with the first generation Janus kinase inhibitors like baricitinib, tofacitinib, and riclositinib? They are actually pan-JAK inhibitors. They are effect on all the JAKs. So, along with the effect, they are going to produce some unwanted effects. For example, the inhibition of JAK1 is leading to the adverse lipid profile in the RA patients. Inhibition of JAK2 is leading to the hematopoietic complications like anemia, thrombocytopenia, neutropenia in the patients treated with JAK inhibitors. So, there comes the importance for selective JAK inhibition and selective TYK2. TYK2 inhibition. So, TYK2 is a Janus kinase which is involved in the downstream signaling of the following cytokines, that is the interferons, interleukin 12, interleukin 23, interleukin 10, interleukin 22, and interleukin 6. So this restricted set of cytokines are targeted. So interferons are involved in the pathogenesis of SLA, dermatomyositis, Sjogren's, scleroderma. Interleukin 12, 23 in psoriatic arthritis. Interleukin 22, you can say it is involved in the pathogens of inflammatory bowel diseases. So when this TYK2 is targeted, all these cytokines, action of these cytokines can be inhibited. And if it is very potent TYK2 inhibition without much effect on other JAKs like JAK1 and JAK2, all the other side effects related to the those inhibition can be prevented. So this is what I said. Approved inhibitors of JAK1, 2, and 3 all affect multiple cytokines. But inhibition of TYK2 would be expected to only affect type 1 and 3 interferons, interleukin 10 family, 12 and 23. So one of the advantages is by not inhibiting interleukin 2, TYK2 inhibition should not suppress interleukin 2. So thus it won't affect the T regulatory cells. And also by not inhibiting interleukin 15, TYK2 inhibition may have a better safety concern when it comes to malignancy risk with JAK inhibitors. So how much is TYK2 inhibition going to be useful? So this is a basic study, a study, Mendelian randomization study, wherein 2 gene banks were studied, the UK Biobank and the FinGen Biobank. Here, they checked if a variant, genetic variant, that is a TYK2 loss of function variant, does it have any association with any autoimmune diseases? So here, looking at the odds ratio, you can see that the TYK2 loss of function variants actually had a reduced risk of diseases like autoimmune hypothyroidism, psoriasis vulgaris, rheumatoid arthritis, etc. Whereas there is an increased risk of congenital anomalies of stomach and feet. So the same results were replicated in the FinGen Biobank too. So this shows that TYK2 inhibition may have a good effect in treatment of autoimmune conditions. And this is a structure of a Janus kinase. So the firm and the SH2 domains are closer to the cytosolic side of the cytokine receptor, and the kinase and the pseudokinase domains are There, the kinase domain is the one which leads to the phosphorylation and activation of JAK. So most of the present using JAK inhibitors competitively attached to this catalytic site, the JAK. This site, the ATP binding site of the kinase domain is inhibited, whereas most of the TYK2 inhibitors that are in trials, they act attached to the allosteric site, that is the pseudokinase domain. Pseudokinase domain has an inhibitory effect on the kinase domain. So if pseudokinase domain is activated, it leads to inhibition of kinase domain, which leads to inhibition of JAK activation, and thus the downstream pathway. And another advantage of allosteric inhibition is it provides better selectivity. The TYK2 inhibitors have better selectivity for TYK2 than JAK1, JAK2, or JAK3. So these are the three TYK2 inhibitors which was initially tried. The trials were done, the deucravacitinib, beprocitinib, and roxacitinib. Deucravacitinib is the one which has 100 times more selectivity for TYK2 when compared to JAK1, 2, and 3. But beprocitinib has both TYK2 and JAK1 inhibition, and roxacitinib has both TYK2 and JAK2 inhibition. Hence, though the trials were showing advantages in psoriasis or psoriatic arthritis or inflammatory bowel disease, they showed better response with beprocitinib, but the side effect profile was almost similar as the current first generation cytokine JAK inhibitors. But deucravacitinib, it was found that they have a good response against placebo in psoriasis. There are 2 trials which led to the approval by FDA for use of deucravacitinib in moderate to severe plaque psoriasis. Phase 2 trials have also been done in psoriatic arthritis and SLE, where better response have been seen against placebo in psoriatic arthritis as well as SLE. Some in vitro studies in SLE has shown that the effect of TYK2 inhibition is as good as the type 1 interferon receptor inhibition at anifrolumab, but it has not been compared head to head. The trials in beprocitinib and roxacitinib is currently not done now. They have stopped all the trials. So this is the only TYK2 inhibitor which has been approved, FDA approved, which is used in moderate to severe plaque psoriasis. It is based on 2 studies, the Poetic Psoriasis 1 study and the Poetic Psoriasis 2 study, where they compared moderate to severe psoriasis, their PASI 75 response at week 12 and 24 and 52 against placebo and apremilast, where it was found that it had a better effect than placebo and apremilast. As well as in the Poetic SO2 study, they did a maintenance study also, where it was found that continuing the patients who had a good PASI 75 response on deucravacitinib had a better maintenance of the response than switching to placebo. This is the similar study in psoriatic, a phase 2 study in psoriatic arthritis, which also showed a better result when compared, better ACR20 response when compared to placebo, both 6 milligram and 20 milligram oral deucravacitinib. When it came to the side effects, no severe adverse effects were reported. The only adverse effects were minor upper respiratory infections. No increased herpes zoster infection was seen, but herpes simplex infections were more seen in the deucravacitinib group. And this is for safety consideration. As I said before, zoster reactivation is less common with deucravacitinib than with other JAK inhibitors. At present, no increased adverse events in respect to cardiac events or thrombotic events were seen, but a longer follow-up is required to see if it is present or not. These are the ongoing trials. So if the ongoing trials shows better good potency and better safety profile, this is going to be a game changer in management of several autoimmune diseases. Thank you.
Doctor, this deucravacitinib, you said there's no cardiovascular compared to the class 1, the earlier JAK
First
inhibitors.
generation. At
But in
present,
other
at
psoriatic
present,
trials also, where the other JAK inhibitors, did they cause cardiovascular?
in general, JAK inhibitors have been shown to have, the initial studies had shown in the
I'm talking in
RI trial,
psoriatic, I'm asking.
psoriasis, I have not checked.
In general. So this is in psoriasis. This is a trial psoriasis.
Yes, psoriasis.
So you
But
can't
in
really say
general,
it's-
because of the JAK1 inhibition, it has JAK1 inhibition is responsible for the negative lipid profile changes, which can lead to the adverse cardiovascular effects. That effect will not be seen in the STIC2 inhibition. So it probably will lead to a good safety profile. It is hypothesized like that, but only on long-term follow-up you will be able to see.
Yeah, thank you. So moving on to the next topic.
Thank you, ma'am, for such an insightful session. I call upon the next speaker for the day, Dr. Sridevi S. She will be speaking on the topic SGLT2 inhibitors in lupus nephritis. I request our chairperson to introduce the speaker.
Sridevi is another one who needs no introduction to this crowd. So let her start the talk.
So, good evening, all. At the outset, I would like to thank the organizing team for giving me this opportunity to deliver the talk on SGL2 inhibitors in lupus nephritis. So, briefly about the timeline of approval of SGLT2 inhibitors. So initially, this is one of the anti-diabetic drugs. So initially, the whole thing happened when the OHA, that is oral anti-hypoglycemic drug rosiglitazone, had few cardiovascular side effect. So hence, FDA released guidelines that the other OHAs which are released in the market, they also have to be assessed for their cardiovascular safety. And hence, all the other drugs which were introduced in the market, and that is one of which is the SGL2 inhibitors, they were also underwent this cardiovascular risk assessment through this trials like EMPA, REG outcome, CANVAS, DECLARE, etc. So in all these trials, it was found that they had a good cardiovascular outcome benefits. That is, it decreased the heart failure, decreased the mortality issues due to the heart failure and the hospitalization due to heart failure and MI. And on the long run, it had a good cardiovascular outcome. But side by side, simultaneously, they found out that it had a good kidney outcome also. That is, it reduced the proteinuria and it reduced the progression of a CKD to the end stage renal disease. And hence came the dedicated renal trials like CREDENCE, DAPA CKD, and EMPAS kidney. So CREDENCE was done on CKD patients who were diabetic. So in them, it was found that 20 to 30% of the diabetic patients who were CKD, they had a less chance of progression to end-stage renal disease. And DAPA CKD was studied on proteinuric CKD, that when those patients were not diabetic. So morely they focused on IgA nephropathy. They also showed a very good response. That is, it decreased the proteinuria to about 39%. And the final one was the EMPA kidney, which studied the non-proteinuric CKD. That is CKD patients who had a very low GFR and they also had a very good outcome. Like the progression from the CKD to the end stage renal disease was reduced to about 30%. So hence came the idea that the current renal protective measures that was applied on our lupus nephritis patient could be applied with the SGLT inhibitors as well. So a little bit about the physiology. So this is the proximal renal tubule. So our SGL2, there are 6 transporters, 6 sodium glucose transporters, of which we are interested on 1 and 2. And one is located in the distal proximal convoluted tubule and intestinal border. And SGL2 is exclusively expressed in the proximal convoluted tubule. So it is just exclusively expressed on the PCT. So what usually happens is that in diabetic patients, there will be the sodium glucose transportation, it will be absorbed through the SGLT inhibitors and SGLT channel. So less amount of, and this SGLT is more expressed in the diabetic patient. So the sodium and the glucose will be co-transported in the proximal convoluted tubule in the diabetic patient. So when the rest of the fluid reaches the distal convolute tubule, that is sensed by the macula densa. So the sodium, since the sodium and glucose are more absorbed in the proximal convoluted tubule, less amount of it reaches the macula densa. So what happens? So the macula densa will signal it as a low intravascular volume signaling. So that leads to afferent arterial dilatation and efferent arterial constriction, which leads to increase in glomerular pressure, thereby increasing the proteinuria. That means hyperfiltration will occur, so more amount of protein will be lost in the urine. But when we apply the SGLT inhibitors, what happens? The sodium and glucose transportation is inhibited because of our inhibition. So less amount of it more amount of it is delivered to the macula densa, and that leads to the afferent arterial constriction and efferent arterial dilatation. So that leads to intraglomerular pressure decrease and decrease in filtration of the protein into the urine. So that reduces the proteinuria in the urine. So that is the basic principle. So why is it recommended in SLA? So basically, there is a high cardiovascular risk for patients with lupus nephritis, and that is more so in the first year, and it increases, and after that in the last 10 to 15 years thereafter. So the relative risk of atherosclerosis for this SLE and lupus nephritis patient when compared to the general population is more. And of course about the heart failure and other cardiovascular risk events. And mortality is also very high when compared to the general population. Heart failure and SLE is a deadly combo that can result in high mortality. So that is why this cardiovascular benefit can be applied to the lupus nephritis patient. And as well as 40% of SLE patients, they develop lupus nephritis over a period of 10 years. And that is very high in lupus nephritis class 4. That is, it reaches about 44%. And in developed countries, it is said to be 17%. So, but in the observational study, which was done in Toronto, it showed that the patients who were on nephroprotective strategies like RAS inhibitors and all, they found that over a period of 10 years, only 62% of the patients who are SLE, they didn't develop any CKD or end-stage renal disease. And hence, the idea of it being reproducing the SGBL2 idea and inhibition in the lupus nephritis to reduce the proteinuria. Other than reducing proteinuria, it has anti-inflammatory action also. It acts on T cells, decreases its T cell activation and proliferation. It affects the polarization of macrophages. It decreases the reactive oxygen species formation. And since less amount of sodium is getting absorbed because we are inhibiting the sodium glucose transport. So when sodium inhibition occurs, what happens is that less amount of work is being done. So hence the demand for oxygen is less, and renal hypoxia will be less, and more amount of ATP will be generated, and that leads to less utilization and more generation and less demand because we are not absorbing the sodium. So it basically inhibits the inflammation through the inhibiting the mTOR pathway, and it activates the autophagy. So that is a protective mechanism to inhibit the podocyte injury. So lupus nephritis, one of the mechanism is that it causes a podocyte injury. So by inhibiting the mTOR pathway, which causes the anti-inflammatory signaling, it inhibits the mTOR pathway inhibition as well as it activates the autophagy, which is protective for the podocyte. So these are the few trials. So these were done. First was the sodium glucose transport inhibitors, which were and nephritis patients having SLE and diabetes, and they were assessed for the onset and progression of lupus nephritis, kidney and cardiac outcomes in patients with SLE and type 2 diabetes. So these were SLE and diabetes patients. They followed, it was a retrospective cohort study, and their records for about 5-year records were taken, and they assessed the onset and progression of lupus nephritis who were on SGPL2 as well as not on SGPL2. So it had a significantly lower risk of lupus nephritis, dialysis, kidney transplant, heart failure, and all-cause mortality. So that was so this was one of the studies. And then Morales did a study where 5 patients who had a biopsy proven lupus nephritis. It was found that they were put on empagliflozin 10 mg daily for 2 months. it was found that the proteinuria decreased from 2.2 gram to 1.2 gram per day in a matter of 2 months. But there was no significant change in GFR. And this was a safety trial, phase 1-2 trial, which used dapagliflozin in standard of care along in SLE patients with or without LN. So here 6 months monitoring was done. It was on 38 patients, of whom 17 patients were lupus nephritis and 13 were biopsy proven. Most of them were class 5. So about 9 of them were on prednisolone more than 20 and 25 of them were on cyclophosphamide or MMF. And 19 adverse effects were attributed to the dapagliflozin, of which only 2 serious infections, that is the fungal pneumonia and SLE flare could be seen, and 1 UTI. And reasonably good safety profile. But it didn't have any effect on disease activity, and BP and BMI improved. So it was SGL2 inhibitors alleviated the podocyte damage in lupus nephritis. So they by decreasing the inflammation and enhancing autophagy. So empagliflozin were applied on the lupus prone mice to explore the renal protective effects, and in them it was found that the mouse anti-dsDNA antibodies, serum creatinine, and proteinuria were decreased over a period of 10 weeks. And renal pathology assessment, it was found to have good improvement in the inflammation in the interstitium as well as the glomerular. And it was found that SGL2 expression were increased and co-localized with the synaptopodin. And it decreased the inflammation and enhanced the autophagy. So that was it's a graph showing decrease in anti-dsDNA, complements, creatinine, etc. And the histology was also studied. And a little bit about the adverse effects. So genitourinary infections, UTI is one of the urinary tract infection is one of the common side effect. And here, because more amount of glucose is getting passed in the urine, they can have a candiduria and UTI. So they have to be checked on serial visits for any symptoms of urinary tract infection, any fever, suprapubic tenderness, etc. So one of the dreaded complication is diabetic ketoacidosis. Even if they have normal glucose level, they can have ketosis. Why? Because they switch over the metabolism from carbohydrate to lipids, and leading to enhanced ketone production. So ketoacidosis is one of the very dreaded side effect, and glucose being normal. So anybody, even though sugars are normal, we need to check for ketoacidosis. And hypoglycemia, it's not that very common. And hypotension, because there is a natriuresis, lot of sodium is being lost. So there is intravascular depletion, which can lead to hypotension. And there will be a transient decrease in GFR also. There can be fragility fracture because of the decrease in blood volume, hypotension. And lower limb amputation is also one of the complications which has been reported with canagliflozin. So take home points. So it is appropriated for patients with mild to moderate decrease in GFR, and particularly those with high level of proteinuria. Once they are on maintenance dose of immunosuppressant, we can add it, and it should be added after along with AC inhibitor. And it's the effects are seen on long run rather than short, because initially when we add, there can be a little decrease in GFR that leads to alarm, or it's alarming situation. So we need to wait for longer results. So, and the EULAR and KDIGO guidelines mention SGL2 inhibitor as one of the renal protective strategy also, and hence it can be applied in the therapeutic armamentarium for lupus nephritis. Thank you.
Thank you, Sridevi. We can take one question.
I have a general comment to make. See, it's not easy to submit the data and the knowledge in the areas of therapeutics, diagnostics, where our own personal experience is few years away. So I would like to thank and congratulate Dr. Sridevi, Anjana, and Abita for delivering such wonderful talks. Thank you.
Thank you, sir.
The next session is on prevention of rheumatoid arthritis. What does evidence tell us? I would like to call upon the speaker, Dr. Harikrishnan B. I request our chairperson to introduce the speaker.
Dr. Harikrishnan is a consultant rheumatologist at Medical Trust, Kochi. Over to you.
At the outset, I would like to thank the organizers of Keracon 24 for giving me this opportunity. My topic for a short presentation is prevention of rheumatoid arthritis. What does evidence tell us? So we all know this is the natural history of rheumatoid arthritis, where there is a non-articular stage and there is an articular stage. The non-articular stage, there is initial breakdown of tolerance, where the genetic and environmental factors lead to generation of detectable systemic or local autoimmunity. In the the next stage is a systemic autoimmunity, where there can be autoantibodies present in the mucosa or in the blood. Next stage, there can be symptoms, but there is no clinical inflammatory arthritis. The inflammation can be detected through imaging. And the next stage, there is clinical RA. So, as rheumatologists, what our this thing is to do the secondary prevention, tertiary prevention, and then treat clinical RA. That is from the stage of systemic autoimmunity onwards. So, what are the key factors to develop an effective RA prevention? We have to identify, define, and accurately risk stratify individuals who are at risk for rheumatoid arthritis. We have to develop infrastructure to identify them. We have to understand the different stages in which they are present, and also we have to design clinical trials so that we can develop new agents to so that we can prevent and treat rheumatoid arthritis at specific stages. So, what aspects of prediction are important? A person, how much he is at risk, and if it has risk, will he ever get rheumatoid arthritis? And if he gets rheumatoid arthritis, when will he get? And if he gets, what type and severity will he get? So the initial studies that help us to find out the risk factors for rheumatoid arthritis were nested case control studies and biobanking studies, which showed that autoantibodies are elevated in the bodies of rheumatoid arthritis patients many years before the onset of clinical symptoms. The newer studies are prospective longitudinal studies. Many studies are there. Three important studies are mentioned here, in which the Steinberg et al. Showed that five parameters in the history and two parameters in clinical examination, if more than three of these seven are present, we can predict clinical RA with a sensitivity of 90% and a specificity of 70%. In the study by Von Destart showed that if we use these clinical parameters along with different combinations of autoantibodies, a score between 7 to 13 can predict inflammatory arthritis in the next 24 months with a 64% chance. And the most recent study is from Leeds, who studied 455 ACPA patients with musculoskeletal complaints. They give two scores, the simple score and the comprehensive score. The simple score consists of four parameters, which can be used in by a primary physician, and the simple score of more than or equal to 18 was associated with a positive predictive value of 27% for developing clinical RA within 1 year. And the comprehensive score can be used by a rheumatologist. This includes 13 parameters, including imaging findings and genetic findings. And the positive predictive value over a particular value was 70% within for development of rheumatoid arthritis within 5 years. So, what a physician should consider while interpreting these results? Most of the studies are done on clinical patients, when we are thinking about prevention, we have to look into the target population. The general population should be the main target. That's what I feel. And so, when the results are applied to the general population, the results can vary. For example, the EULAR parameters, when we apply it to the general population, the positive predictive value decreased to 3% as compared to 30% when it was applied to the clinical patients. And when we study the retrospective and prospective study usually overestimates the risk. So we need more prospective population-based studies to find out the risk factors in clinical RA. And we have to keep in mind that only the third generation ACPS are predictive for clinical rheumatoid arthritis. So based on these studies, the at-risk state has got a genetic environment importance. The immune dysregulation is important. The symptom complex, which is usually intermittent joint pains, which is less than 1 year in onset, and with early morning stiffness of more than 30 minutes, and local inflammation, which can be detected through imaging. And coming to some of the important trials for prevention of rheumatoid arthritis, dexamethasone was studied. Dexamethasone 100 milligram, 2 doses, 6 weeks apart was studied and compared to placebo. But there was no difference in the incidence of clinical RA after 26 months, but showed that dexamethasone use was associated with a decrease in autoantibody level. Rheumatoid arthritis rituximab was studied in the prior study. A single dose of 1 gram rituximab along with steroid was given, but there was no change or difference in the incidence of clinical RA between the two arms, but rituximab was associated with a delay in the onset of inflammatory arthritis. Study using atorvastatin was a failure. Then methotrexate was studied in the treat earlier study, in which a single dose of methylprednisolone 120 milligram along with methotrexate up to 25 milligram per week was given for 1 year, And after 2 years, the study showed that there was no difference in the incidence of clinical RA, but the study showed that patients treated with methotrexate has got the severity of the disease was less. And coming to the vital study where vitamin D and omega-3 fatty acid was studied, it showed that 2000 international unit per day of vitamin D with or without omega-3 fatty acid helped to reduce the incidence of autoimmune disease including rheumatoid arthritis by 22%. The STOP RA trial using hydroxychloroquine in these patients, hydroxychloroquine 200 to 400 milligram per day was given for 1 year, and the study and it was evaluated after 2 years and showed that there is no difference between the two arms for the incidence of clinical RA. The trial is now halted. This was the interim report. The final analysis is pending. And abatacept was shown to be some benefit in prevention of RA. There are two important studies. One is the APIPRA trial in which the antibody positive individuals with arthralgia was studied. Abatacept 125 milligram weekly injection was given for 1 year, and that was study and the analysis was done after 2 years, and it showed that there is significant decrease in the incidence of inflammatory arthritis in the abatacept arm. Patients with the triple positive antibodies, that is ACCP, rheumatoid factor, and anti-CARP antibodies were found to have, there is more tendency to develop rheumatoid arthritis, and these patients, the triple positive patients, responded best to abatacept. And coming to the area trial, where the anti-CCP positive patient with MRI evidence of joint inflammation was studied. Here, abatacept 125 milligram was given every weekly for 6 months, and analysis was done after 18 months. It showed that there is significant decrease in the inflammation, MRI evidence for inflammation in the abatacept arm, and also there was significant decrease in the incidence of rheumatoid arthritis in the abatacept arm. So, in a nutshell, the short-term use of corticosteroid, rituximab, atorvastatin, methotrexate, and its hydroxychloroquine have not significantly prevented inflammatory arthritis or rheumatoid arthritis. Rituximab delayed the onset, methotrexate decreased the severity of the disease. Abatacept has proven to be efficient. And what the physician should consider while interpreting this result, most of the studies are again from clinics. Only the vital study and 1/3 of the patients in the STOP RA trial was from the general public. So we have to go a long way before using these agents or applying these results in the general population. Already approved medicines were used in these trials in whatever doses that they like, and so maybe more studies we can do with the same agents with different dosings can help to give a good result. In the abatacept trial, that is the area trial, we have seen that in the placebo arm also, there was a decrease in the inflammation, MRI evidence of inflammation by around 29% in the placebo arm also. So that showed that the inflammation, most of us may use the MRI or USG evidence for inflammation to start a disease modifying agent in the treatment of patients with just joint pain and no clinical evidence of inflammatory arthritis. So in that trial showed that 29% there was a decrease in inflammation even without starting a disease modifying agent. So we have to consider that also, and the overall rate of progression to clinical RA in the placebo arm in these studies were from 14 to 57%. So more robust risk stratification measures are needed. And we have to keep in mind that it is possible for an individual to progress or regress from a given stage. So how should a physician manage an individual who comes to you with a potential risk for clinical RA? Till now, there are no pharmacological agents that are approved by FDA for prevention of rheumatoid arthritis, and there are no formal guidelines to establish till now. What we can do is determine if there is any clinical rheumatoid arthritis present, and if autoantibodies are present, we have to rule out other causes, especially if, we have to evaluate, especially based on the symptoms of the patient. Then we have to discuss the rate of progression to clinical RA, especially if ACCP is positive, there is 20 to 30% chance that he can develop RA in the next 3 to 5 years. We have to educate about the signs and symptoms. We have to do routine follow-up to pick up the disease early. Lifestyle interventions like smoking cessation, exercise, optimal body weight management, and oral hygiene maintenance is needed. But there are no RCTs to show that these interventions can prevent rheumatoid arthritis. We have to treat clinical RA if it is present, and we have to update ourselves with prevention strategies. Based on the different, we have many checkpoints which are not working in a rheumatoid arthritis patient, so we have to do many agents, find out many agents which can work at different stages of the disease so that we can practice a personalized medicine. Till now, only one agent has been approved by US FDA for delaying an autoimmune disease, that is in type 1 diabetes, which is teplizumab. So a single 14-day course of teplizumab helped to decrease or delay the onset of type 1 diabetes by more than 2 years. So that is this thing. And to conclude, autoimmune diseases are reliable and rheumatoid arthritis prevention may be achievable. At-risk state can be identified, risk stratification can be performed, and interventional trials can be carried out successfully to some extent. More well-structured studies are needed, especially population-based studies are structured, and in the absence of guidelines for disease-modifying agents should not be initiated in at-risk individuals, and CVD prevention has transformed the healthcare. In the same way, autoimmune disease prevention can also be of lot of benefit to the patients. Thank you.
Any talk? Any questions?
Great talk. One question was omega 3, does it have any role? There was a study in large population based study where omega 3 prevents onset of autoimmune disease even after you stop it. For around 5,000 patients, vitamin D and omega 3.
That is a vital study, sir. Vital study showed that vitamin D 2000 rational unit plus or minus omega 3 fatty acid.
But omega 3 had a more effect, long lasting effect, no?
In that it was, yes, it is mentioned like that, sir. It has a long lasting effect. But the final conclusion, they mentioned it like this thing, which is the mainly vitamin D, which is more helpful than omega 3.
Thank you.
Thank you, Dr. Harishna. Move on to the next topic and the last topic of the session.
Coming to the last session of short topics, it's on uveitis in juvenile idiopathic arthritis and its management by Dr. Anirupa Vijayan. I request the chairperson to introduce the speaker.
I'd like to welcome Dr. Andropa, consultant rheumatologist at Care, to talk about this dreaded complication in JAA.
So first of all, I would like to thank the organizers for giving me this opportunity. Coming to the topic, so we'll be discussing management of JAA uveitis. So brief introduction to uveitis. So uveitis is anatomically classified into three, that is anterior uveitis, intermediate uveitis and posterior uveitis. So anterior uveitis include iridocyclitis, anterior cyclitis and iritis. Intermediate uveitis include inflammation of the vitreous. And there is posterior uveitis with involvement of the retina and the choroid. Then there is a standardization of uveitis nomenclature grading for anterior uveitis. This is based upon the number of cells that are present in the anterior chamber that is visualized through a split microscope. So this is graded from 0 to 4+. Then there is also a grading based on the anterior chamber flare. Flare actually indicates the amount of protein that is present in the aqueous humor. So this is also graded based on 0 to 4+. The importance of anterior chamber flare is it is associated, high flare is associated with vision loss. So the definition for remission in anterior uveitis is basically absence of cell, that is 0 cells in the field. This is a brief etiology of uveitis in children. So majority of the uveitis in pediatric population is mainly non-infectious and it is usually asymptomatic and usually having a chronic course. So definition of acute uveitis, it is duration of uveitis less than 6 weeks. Recurrent is repeated episodes of uveitis which are separated by periods of inactivity of more than or equal to 3 months in duration without any treatment. Then there is a chronic persistent uveitis that is characterized by relapse in less than 3 months after discontinuation of the therapy. So JAA, it is one of the most important cause of uveitis in children. And uveitis occurs as a complication in JAA, that is around 20 to 30% of the children with JAA can have uveitis. And predominantly uveitis occurs after arthritis, that is it usually occurs 4 to 7 years after the onset of arthritis. But in small percentage, that is 3 to 7%, uveitis can precede arthritis. And as we know, oligoarticular JAA is more prone for developing uveitis, that is 20%, and the least chance is for polyarticular JAA. The importance of uveitis in JAA is that it is usually asymptomatic and it is usually white eye, so it is misdiagnosed and can lead to vision loss. So this is one of the long-term follow-up cohort of JAA, that is 18 years follow-up from a population-based Nordic cohort. Around 434 JAA patients were followed up for a period of 18 years. Out of these, 96 children had uveitis. And the most common presentation among these children were anterior uveitis. And majority of the children were non-symptomatic, that is 72.4%. And majority had persistent uveitis. And the other important finding was that even at 18 years of follow-up, around 23% of the children had activity in the anterior chamber, that is sun grading 0.5 to 1 plus. So complications in this cohort identified, the most important, around 38.8% of the children had at least one ocular complication. And the major complication identified were cataract, glaucoma, and posterior synechiae formation. And these complications occurred mostly in the children who had uveitis preceding the onset of arthritis. Other important complications are macular edema, band keratopathy, epiretinal membrane, and hypotony and phthisis. So the risk factors for the development of uveitis in JAA, it is mainly the female gender, oligoarticular JAA, younger age at the onset of JAA, that is less than 6 years of age, and the presence of antinuclear antibody and HLA B27 positivity. And once they develop uveitis, who all are at the risk of developing complications? So male gender, onset of uveitis before arthritis, and short interval between the onset of JA and uveitis, and the prevalence of ocular complications early in the course of the disease. So these category are more prone for ocular complications. Coming to the treatment part, we can divide it as, this treatment should be done as a teamwork between the rheumatologist and ophthalmologist. And the treatment part include topical or local therapy, systemic therapy, and surgery if ocular complications occur. So treatment, we'll discuss with a case. This is a 8-year-old girl presented with 2 years history of oligoarticular JAA. She was on methotrexate 5 mg per week and her joints is in remission. And routine ophthalmic examination showed anterior chamber cells grade 2+, AC flare 2+, and OCT showed macular edema. So what is the next treatment option to be considered? So whether we should add only on topical steroids or whether we should consider systemic steroids, or is it necessary to hike the dose of methotrexate only, or whether we need to add adalimumab. So role of topical steroids in JA uveitis management. Topical glucocorticoids preferred one are prednisolone 1% and dexamethasone 0.1%. So this is considered as a first-line treatment in the absence of poor prognostic factors. And the accepted dose that is allowed for maintenance therapy is 2 drops or less of topical glucocorticoid over a period of maximum 3 months. And when to consider systemic therapy in uveitis? So systemic immunosuppression is recommended if there are poor prognostic factors or if persistent disease is present. And the poor prognostic factors identified are ocular complications, male sex, and uveitis preceding the arthritis. So the common ocular complications, as I mentioned earlier, it is the posterior synechiae, band keratopathy, glaucoma, cataract, macular edema, and vitreous opacification. So coming to the role of systemic steroids, it is indicated in sight-threatening JA uveitis, that is with the macular edema. Then it can be used as a bridge therapy to DMARDs, and also rescue treatment if the patient develops macular edema. And perioperatively, during cataract or glaucoma surgery, we have to hike up the immunosuppression with steroids. And systemic therapy with the steroids is advocated usually less than 3 months. And coming to the role of DMARDs, methotrexate is the first DMARD that is used for the management of chronic anti-uveitis and JA uveitis. And mycophenolate mofetil is another option. And other options being azathioprine, leflunomide, or cyclosporine. But there are no expert consensus regarding the use of these agents. And when to consider anti-TNF therapy in JA uveitis? It is indicated if there is intolerance or inefficacy to methotrexate or other conventional synthetic DMARDs. So this is one of the important trial, that is ICOMOR trial 2017, with regard to the use of adalimumab in JA uveitis. This is a randomized trial, multicentric trial. In this, 90 patients were included with JA uveitis. 60 patients received adalimumab with methotrexate and 30 patients received placebo with methotrexate. And this trial clearly showed that the treatment failure with methotrexate adalimumab combination was less when compared to that of the placebo arm. This again adjuvant trial, this again another trial with adalimumab that showed efficacy of adalimumab as early as 2 months of uveitis. And these are the other biological drugs that we used in JAA, that is adalimumab, infliximab, golimumab. Etanercept is not recommended in the use of uveitis. Then there is tocilizumab aptitude trial, but the trial did not meet the primary endpoint. Others are abatacept, rituximab, baricitinib, and tofacitinib. And what to do if the patient fails on adalimumab? So first, we can escalate the dose of adalimumab to weekly dose, and we can shorten the interval. Then if it fails on above thing, you can switch to another anti-TNF agent. And the usual second line of anti-TNF that is preferred is infliximab. And if unsuccessful, you can change the class of drug to tocilizumab, abatacept, or rituximab. And when to decrease the dose of DMARD. So that is reduction of the dosage is attempted if drug-induced remission is maintained for at least 2 years. And gradual reduction is advisable rather than by increasing the dose space between the doses. And the ADJUST trial, this is an ongoing trial. This is the first RCT to assess the efficacy of discontinuing adalimumab once the remission is attained for at least 12 months. And coming to the use of baricitinib, this is an ongoing trial, that is JUVI-BRIGHT trial, to study the clinical effectiveness and safety of baricitinib for the treatment of JAA uveitis. And our case, that was a 8-year-old girl with a 2 years history of JAA, and she had macular edema. So the next option, whether to consider topical or systemic steroids. Since she had macular edema, which is a complication, we should consider systemic steroids first. And hike the dose of methotrexate or adalimumab. So recommendations say first to optimize the dose of DMARDs, and if not attained remission, we can consider adding adalimumab. And this is the monitoring that we have to do when a patient have JAA. Oligoarticular JAA, ANA positivity, you have to screen the patients 3 monthly. If it is ANA negative and age more than 7 years, and more than or equal to 4 years of age, you can screen every 6 to 12 monthly. If the patient is having uveitis but is in tapering dose of medicines, the patient is on tapering dose of topical steroids, you have to monitor the patient within 1 month. And if the patient is on tapering dose of systemic therapy, you have to monitor the patient 2 monthly. And any patient on of JA uveitis, you have to screen the patient for 6 to 12 monthly. And take home message, uveitis can occur in 10 to 30% of JAA patients, particularly oligoarticular JAA. Majority of these JAA patients are asymptomatic, so we have to closely monitor for development of uveitis in this group. Early diagnosis is very important, and slit lamp examination is the gold standard. And close communication between pediatric rheumatologist and ophthalmologist is very important. And educating the family is also important, as they have to monitor the signs to watch for and the importance of regular eye checkup. And treatment options include steroids, immunosuppressive therapies, and biologics. So the timely intervention is very important to prevent vision loss, as majority of these cases are chronic and they may not be diagnosed early.
Very nice, Anurupa. A few clarifications actually. One is that anytime you diagnose a child with JIA, whatever form of JIA, whatever age, you should make sure they are screened for uveitis. Okay, whatever age. And of course, it's now actually the classification of JIA is changing. And we're going to have a group called the early onset ANA positive JIA. Doesn't matter whether they're oligo, polyarticular, nothing. This is a group that has the highest risk for uveitis. And you have to be very careful in this group. And to be honest, your example case, which probably isn't a real case.
No, ma'am.
Yeah, because I would feel very sad if a child has been on treatment for 2 years and has now only been discovered to have uveitis because the child has not been screened or been followed up. That's what it means. Pediatric uveitis is very different from adult because the majority are non-infectious, unlike what you see in adults. The majority are chronic, not acute, except maybe in areas where HLA-B27 diseases are very, very high. We see a lot of chronic non-infectious uveitis. We just presented our paper in APLAR, which had 82 patients, 139 eyes. So we see a lot of patients. Okay. So the thing is, what I'll tell you is we really have to lead. The rheumatologist has to lead here. Ophthalmologists across the country, except for very, very few, to be honest, are clueless when it comes to pediatric uveitis. Even the instinct that they need to be referring to a rheumatologist is kicking off only recently. For a long time, they just used to give drops and drops and drops and continue managing for a very long time. And drops are damaging. Most of the complications that happen in uveitis happens due to disease and happens due to topical medications. Okay, the incidence of cataract, glaucoma, blindness, very high. So that's why you have to be very, very aggressive with treatment up front with these patients. I don't play around with oral methotrexate in these patients. Subcutaneous, the max dose you can go up to. And believe me, this 15 milligram per meter square, etc. When it comes to uveitis, you're talking 20 milligram per meter square. Or I go by the other rule where we go by 0.3 to 1 milligram per kilo per week. For the younger children, that's a more suitable way to dose them rather than just go, because in older children most of the time you'll get to 20 and all that, but in younger children, a 15 kilo child, I'll be happily giving them 12.5 milligram this thing. An 8-year-old girl on 5 milligram methotrexate makes me wince, actually, really wince. That's too tiny a dose to matter. And methotrexate has to be upfront. Rarely use systemic steroids unless there is posterior segment involvement, where obviously no drop is going to get in. Ciliary hypotony is a red flag, major red flag, because that's one of the situations where you'll definitely have visual loss. Prognosis can be very, very poor. So you have to be very aggressive with those patients. There are few patients for whom up front we have started methotrexate, adalimumab straight away. Okay, so you have to be really aggressive. Otherwise, the risk of complications is very high. In the developed world, the highest cause of acquired blindness is non-infectious uveitis in children. Okay, so it's not something that we sit down slowly think about, etc. It's not like that. And do remember, our ophthalmology colleagues are still not adequately educated on the real aggressiveness of this problem, and we have to preempt. I had the fortune to work with someone who's really, really good, who's very well aware of disease and can guide and sing very well. So we had a lovely collaboration, but you may not all be fortunate in that regard. So you have to be very aggressive with these patients. And no oral methotrexate, please, especially in the early phase. These patients, you have to be very aggressive, subcut and nothing else. And even if they are taking weekly methotrexate, 2 weekly adalimumab injections, doesn't matter. You have to be, the parents will crib, the child might crib, but you know what is the thing. When you have seen children go through numerous surgeries, lose their sight, you know what devil you're chasing here.
Just one question: is there any data that early initiation of methotrexate in JA prevents the development of uveitis? There is data prevents the incidence of.
You tend to see less of, the oligo patients is the only one where you can do this, because poly patients will always get methotrexate upfront. But in the oligo patients who you treat just with intraarticular injections and follow them up, the risk of them coming up with uveitis, new uveitis, is much higher than you will see in the polyarticular patients, the younger ones, who are also Na positive, who are already on methotrexate. So that probably answers your question. It would probably be unethical to do a full-on trial because the polyarticular patients cannot be denied methotrexate.
Thank you, Dr. Anurupa, for that enlightening session. With that, we come to the end of our first session. I thank our chairpersons. I kindly request all the delegates to please be seated. We will have the official inauguration shortly. Once again, a very good evening to one and all present here. Firstly, I would like to invite our esteemed dignitaries onto the dais. It's my honor and privilege to invite Shri K.C. Venugopal Sir, Honorable Member of Parliament, Alappy, onto the dais. Dr. Padma Kumar Sir, President, IRA Kerala Chapter and Organizing Secretary, Keracon 2024. Dr. Padmanabh Shenoy Sir, Secretary, IRA Kerala Chapter. Dr. Vinod Ravindran Sir, Honorary Secretary, IRA. Dr. Arun N, IMA President, Alappy. Dr. Vishnu S. Chandran, Joint Organizing Secretary, Keracon 2024. And Dr. Hari Krishnan G, Scientific Committee Chairman, Keracon 2024. Thank you. Please rise for the prayer.
നന്മയാകുന്ന കാന്തി കാണുവാൻ കണ്ണിനാകേണമേ, നല്ല വാക്കിൻ്റെ ശീലു ചൊല്ലുവാൻ നാവിനാകേണമേ, സ്നേഹമാകുന്ന ഗീതമോ എൻ്റെ കാതിനിണയാകണേ, സത്യമെന്നുള്ള ശീലമോടെ ഞാൻ ശാന്തി അറിയണമേ. ഭൂമി അമ്മയെന്നറിയുവാനുള്ള ബോധമുണ്ടാകണേ, ജീവജാലങ്ങളാകയും ജന്മബന്ധുവായിടണേ, ജാതിഭേദങ്ങളെന്ന ശാപമോ ദൂരെ മറയണമേ, ലോകമുന്നെന്ന പാഠമെന്നുമെൻ മനസ്സിലെഴുതേണമേ.
I request Dr. Padmanabha Shenoy Sir to deliver the welcome address.
ഗുഡ് ഈവനിങ്. അപ്പോൾ നമ്മളിവിടെ എല്ലാവരും ഒത്തുചേർന്നിരിക്കുന്ന ആലപ്പുഴ എനിക്ക് തോന്നുന്നു IRA കേരള ചാപ്റ്റർ തുടങ്ങിയ സ്ഥലമാണ്. പത്മകുമാർ സാറിൻ്റെ ഞാനൊക്കെ വരുന്നതിന് മുമ്പാണ്, എനിക്ക് തോന്നുന്നു 20-22 വർഷം മുമ്പ്, 2002 അല്ലേ സാർ, 2002. അപ്പം സോ ഇറ്റ്സ് എ മൊമെൻറ്റസ് ഒക്കേഷൻ. ആലപ്പുഴയിൽ തുടങ്ങിയ IRA കേരള ചാപ്റ്റർ ഹാസ് ഇപ്പോൾ എത്രയോ വികസിച്ചു. ബിനോയ് സാറുണ്ട്, ഭാസ് സാറുണ്ട്, ഇവരെയൊക്കെ മെൻറ്റർഷിപ്പിലാണ് തുടങ്ങിയത്. സോ ഇറ്റ് ഹാസ് കേരളത്തിലെ റുമറ്റോളജിയുടെ ഒരു വികാസത്തിന് ചുവട് പിടിച്ച ഒരു ആണിക്കല്ലായിട്ട് നിന്ന ഒരു പ്രസ്ഥാനമാണ് ഇന്ത്യൻ റുമറ്റോളജി അസോസിയേഷൻ്റെ കേരള ചാപ്റ്റർ. 3-4 റുമറ്റോളജിസ്റ്റ് ആയിട്ട് ഉണ്ടായിരുന്ന സമയത്ത് നിന്നും ഇന്ന് കേരളത്തിൻ്റെ എല്ലാ ജില്ലകളിലും 2-3 റുമറ്റോളജിസ്റ്റ് ആയിട്ടും അത് പേഷ്യൻസിൻ്റെ ഒരു ജീവിതത്തിൽ തന്നെ വലിയൊരു വ്യത്യാസം ഉണ്ടാക്കിയിട്ടുണ്ട്. റുമറ്റോയിഡ് ആർത്രൈറ്റിസ് ആണെങ്കിലും SLE ആണെങ്കിലും അതിനെക്കുറിച്ച് അവയർനെസ്സും അതിനെക്കുറിച്ചുള്ള ട്രീറ്റ്മെൻറ്റും വളരെ കൂടുതൽ ജനങ്ങളിലേക്ക് എത്തിക്കാനും അവരുടെ ജീവിതത്തിൽ വ്യത്യാസം വരുത്താനുമായിട്ട് കഴിഞ്ഞ 10-20 കൊല്ലം കൊണ്ട് സാധിച്ചിട്ടുണ്ട്. അതിന് IRA കേരള ചാപ്റ്റർ നടത്തുന്ന ഇതുപോലുള്ള CMEs വളരെ യൂസ്ഫുള്ളാണ്. അതുകൊണ്ട് തന്നെ ഞാൻ പറഞ്ഞു 20 വർഷത്തിന് മുമ്പ് ഇവിടെ തുടങ്ങിയ ഈ പ്രസ്ഥാനം ഇന്ന് ഒരു വലിയ നിലയിലേക്ക്, ഒരു ചെറിയ ഇൻഫൻസി കടന്ന് ഒരു അഡോളസൻ്റ് ഏജ് കഴിഞ്ഞ് അഡൾട്ട്ഹുഡിലോട്ട് പോകുന്ന ഒരു ഫേസിലൂടെയാണ് നമ്മൾ കടന്നു പോകുന്നത്. അപ്പോൾ ഇനി നമുക്ക് വളരെയധികം ചെയ്യാനുണ്ട്. മൈൽസ് ടു ഗോ ബിഫോർ യു സ്ലീപ്പ്, ലോട്ട് ഓഫ് തിങ്സ് ടു ബി ഡൺ. വി നീഡ് ടു വർക്ക് ടുവേഴ്സ് റിസർച്ച്, വി നീഡ് ടു ജനറേറ്റ് അവർ ഓൺ ഡേറ്റ. മാത്രമല്ല നമുക്ക് നമ്മുടെ ഈ പേഷ്യൻസിന് വേണ്ടി ഗവൺമെൻറ് സ്കീംസിലും അഡ്വോക്കസി ചെയ്യാനുണ്ട്. നമ്മളൊട്ടും ചെയ്യാത്തൊരു കാര്യമാണ്. അതുകൊണ്ട് തന്നെയാണ് ഇന്നത്തെ മീറ്റിങ്ങിൽ നമ്മുടെ മുഖ്യാതിഥി ശ്രീ ആലപ്പുഴയുടെ സ്വന്തം കണ്ണൂരുകാരനാണെങ്കിലും എനിക്ക് ഓർമ്മയുണ്ട്, ഞങ്ങൾ പഠിക്കുമ്പോൾ തന്നെ KC എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ ആലപ്പുഴക്കാരനാണ് നമ്മുടെ എല്ലാവരുടെയും വിചാരം. കാരണം അത്രയും നമ്മൾ എന്ത് കാര്യം ഉണ്ടെങ്കിലും മെഡിക്കൽ കോളേജിൽ നമ്മൾ ആലപ്പുഴ പഠിക്കുന്ന സമയത്ത് പോലും അദ്ദേഹത്തെ പോയി കണ്ടിട്ടുണ്ട്. അദ്ദേഹം വളരെ കൂടുതൽ നമ്മൾ ഹെൽപ്പ് ചെയ്തിട്ടുണ്ട്. അപ്പോൾ ഏതൊരു ആലപ്പുഴക്കാരനേക്കാളും ആലപ്പുഴക്കാരനാണ് നമ്മുടെ പ്രിയപ്പെട്ട KC. അപ്പോൾ അദ്ദേഹം ഇന്ന് വളരെ ഉന്നതങ്ങളിലാണ്. എന്നിട്ടും പത്മകുമാർ സാറ് വിളിച്ചപ്പോൾ അദ്ദേഹം സമയം കണ്ടെത്തി നമുക്ക് വേണ്ടി ഇവിടെ വന്നു. അദ്ദേഹത്തിൻ്റെ വളരെ വിലപ്പെട്ട സമയം ഇവിടെ നമുക്ക് നൽകി. ഇപ്പോൾ നിങ്ങൾക്ക് എല്ലാവർക്കും അറിയാമായിരിക്കും, PSC ചെയർമാനാണ്. PSC ചെയർമാൻ ഈസ് ലൈക്ക് എ ക്യാബിനറ്റ് മിനിസ്റ്റർ. അപ്പോൾ ഇനി ഭാവിയിൽ ഇതിനേക്കാളും വലിയ പൊസിഷൻസിലേക്ക് എത്തേണ്ട ഒരു വ്യക്തിത്വമാണ്. അതിനുള്ള കേപ്പബിലിറ്റിയും അതിനുള്ള എല്ലാ ഹാർഡ് വർക്ക് ചെയ്ത് അവിടെ എത്തിയിരിക്കുന്ന മനുഷ്യനാണ്. അപ്പോൾ അദ്ദേഹത്തോട് നമുക്ക് പറയാനുള്ളൊരു കാര്യം എന്ന് പറഞ്ഞാൽ എപ്പോഴും പലപ്പോഴും റുമറ്റോളജി പേഷ്യൻസിന്, ആർത്രൈറ്റിസുള്ള പേഷ്യൻസിന് ഗവൺമെൻറ് സൈഡിൽ നിന്നാണെങ്കിലും ഒക്കെ വളരെ കൂടുതൽ ചെയ്യാൻ സാധിക്കും. അപ്പോൾ നമ്മുടെ പേഷ്യൻസിൻ്റെ കാര്യം സാറ് മനസ്സിൽ വെക്കണം, പറ്റുന്ന രീതിയിൽ സാറ് ഹെൽപ്പ് ചെയ്യണമെന്നൊരു വിനീതമായി അഭ്യർത്ഥിക്കുകയാണ്. അതോടൊപ്പം തന്നെ നമ്മുടെ ക്ഷണം സ്വീകരിച്ച് ഇവിടെ എത്തിയ KC വേണുഗോപാൽ സാറിന് എൻ്റെ പേരിലും IRA കേരള ചാപ്റ്ററിൻ്റെ പേരിലും ഓർഗനൈസിംഗ് കമ്മിറ്റിയുടെ പേരിലും ഈ മീറ്റിങ്ങിലേക്ക് സ്വാഗതം ആശംസിക്കുന്നു. ഡോക്ടർ അരുൺ IMA ആലപ്പുഴ പ്രസിഡൻ്റാണ്. അരുണെന്ന് പറയുമ്പോൾ അരുൺ ഈസ് മൈ ബാച്ച്മേറ്റ്, MBBS ബാച്ച്മേറ്റ് ആണ്. സോ അപ്പോൾ നമ്മൾ പറഞ്ഞാൽ വേറൊരു റിലേഷൻഷിപ്പാണ്. അരുണെന്ന് പറയാൻ തന്നെ, അരുണെ നമ്മൾ വേറെ പല പേരിലാണ് വിളിക്കുന്നത്. അതുകൊണ്ട് അരുണെന്ന് വിളിക്കാൻ തന്നെ പലപ്പോഴും എനിക്ക് 2 പ്രാവശ്യം ആലോചിക്കേണ്ടെന്നു അരുണെന്ന് വിളിക്കാനായിട്ട്. അപ്പോൾ അരുൺ ഈസ് അഗെയിൻ വെരി വെരി ആക്റ്റീവ്. ഇപ്പം IMAയുടെ കേരള സ്റ്റേറ്റ് ജൂനിയർ ഡോക്ടേഴ്സ് ഫോറത്തിൻ്റെ കോർഡിനേറ്ററാണ്. അങ്ങനെ വളരെയധികം ഡോക്ടേഴ്സിന് വേണ്ടി നിലകൊള്ളുന്ന സിൻഡിക്കേറ്റ് മെമ്പറാണ്, സെനറ്റ് മെമ്പറാണ് IMA നമ്മുടെ കേരള ഹെൽത്ത് യൂണിവേഴ്സിറ്റിയുടെ. അപ്പോൾ അങ്ങനെയുള്ള വളരെ ബിസി ആയിട്ട് നടക്കുന്ന കാർഡിയോതൊറാസിക് സർജനാണ്. അപ്പോൾ നമ്മുടെ ക്ഷണം സ്വീകരിച്ച് ഇവിടെ എത്തിയ അരുണിനും എൻ്റെ പേരിലും ഓർഗനൈസിംഗ് കമ്മിറ്റിയുടെ പേരിലും IRA കേരള ചാപ്റ്ററിൻ്റെ പേരിലും ഈ വേദിയിലേക്ക് സ്വാഗതം ചെയ്യുന്നു. പത്മകുമാർ സാർ കുറിച്ച് പറയുമ്പോൾ ഒന്നും നമ്മളെല്ലാം ഒരു ടീമാണ്. സാർ IRA കേരള പ്രസിഡൻറ്റ്, ഞാൻ സെക്രട്ടറിയുമാണ്. പക്ഷേ സാറ് ഹി ഹാസ് ബീൻ മൈ ടീച്ചർ. പണ്ട് 1998 മുതൽ സാറിനെ 20-25 കൊല്ലമായിട്ടുള്ള ബന്ധമാണ്. അന്നോട്ട് തന്നെ നമ്മളെ മെഡിസിൻ്റെ പല പാഠങ്ങൾ പഠിപ്പിച്ച സാറാണ്. അപ്പോൾ മെഡിസിനിൽ ഇൻട്രസ്റ്റ് ഉണ്ടാകാനുള്ള വൺ ഓഫ് ദ റീസൺസ് ഇവരുടെയൊക്കെ നമ്മൾ മെഡിസിൻ പഠിപ്പിച്ചുകൊണ്ടാണ്. അപ്പോൾ സാറ് അതിനുശേഷം റുമറ്റോളജിയുടെ മാത്രമല്ല കേരളത്തിൽ മെഡിസിൻ്റെ എത്ര സിമ്പിളായിട്ട് ജനങ്ങളിലേക്ക് എത്തിക്കാൻ പലതരത്തിലുള്ള പത്രമാധ്യമങ്ങളിലൂടെ സാർ എഴുതിയ എഴുത്തുകൾ വളരെ സിമ്പിളായിട്ട് കമ്മ്യൂണിക്കേറ്റ് ചെയ്യുന്ന ഒരു മനുഷ്യനാണ്. അപ്പോൾ ഞാൻ സാറിൻ്റെ എപ്പോഴും പറയും, സാറ് ഒരു ഭാവിയിൽ കേരളത്തിൻ്റെ ഒരു ഹെൽത്ത് മിനിസ്റ്ററായിട്ട് മുമ്പോട്ട് വരണം. സോ ദാറ്റ് ഹി ക്യാൻ റെവല്യൂഷനൈസ്, ബിക്കോസ് ഹി ഹാസ് ദാറ്റ് ഇൻസൈറ്റ് ഇൻ ടു ദ എൻറ്റയർ തിങ്. അപ്പോൾ സാർ ഇപ്പോൾ ഒരു പ്രിൻസിപ്പളായി, അതിന് സാറിന് ഇനിയും വളരെ കൂടുതൽ ചെയ്യാൻ സാധിക്കട്ടെ. അങ്ങനെ ചെയ്യുന്നതിൻ്റെ ഏറ്റവും വലിയ ഗുണം എനിക്ക് ഐ ആം ഷുവർ റുമറ്റോളജിക്ക് വലിയ ഗുണം ഉണ്ടാകുമെന്നൊരു വിശ്വസിക്കുന്ന മനുഷ്യനാണ് ഞാൻ. അപ്പോൾ സാറിന് ഏത് രീതിയിലാണെങ്കിലും എപ്പോഴും റുമറ്റോളജി ഈസ് ക്ലോസ് ടു ഹാർട്ട്. ഒരു മെഡിസിൻ വർക്ക് ചെയ്യുമ്പോഴും റുമറ്റോളജി പേഷ്യൻസിന് ആലപ്പുഴയിൽ ഏറ്റവും കൂടുതൽ ഹെൽപ്പ് ചെയ്ത മനുഷ്യനാണ്. അപ്പോൾ സാറ് ഞാൻ നേരത്തെ പറഞ്ഞല്ലോ, IRA കേരള ചാപ്റ്റർ ഉണ്ടാക്കുന്നതിനും ഒരു പ്രധാനപ്പെട്ട കാരണം സാറായിരുന്നു. അപ്പോൾ സാർ ഔപചാരികളുടെ പേരിൽ ഈ വേദിയിലേക്ക് ഞാൻ സ്വാഗതം ചെയ്യുന്നു. വിനോദ് രവീന്ദ്രൻ സാർ, അഗെയിൻ അവർ കൊളീഗ്, IRA കേരള ചാപ്റ്ററിൻ്റെ ഇപ്പോഴത്തെ IRA സ്റ്റേറ്റ് നാഷണൽ ചാപ്റ്ററിൻ്റെ സെക്രട്ടറിയാണ്. വെരി വൈബ്രൻറ്റ്. ഹീ ഈസ് എഡിറ്റർ ഓഫ് റുമറ്റോളജി ഓക്സ്ഫോർഡ്, ഹാസ് ഡൺ ലോട്ട് ഓഫ് അക്കാഡമിക് വർക്ക്. കാലിക്കറ്റാണ് സാർ പ്രാക്ടീസ് ചെയ്യുന്നത്. സോ ഹി കെയിം ഓൾ ദ വേ. താങ്ക് യു and welcome to the dais. Vishnu and Hari, എനിക്ക് തോന്നുന്നു ഈ IRA കേരള ചാപ്റ്ററിൻ്റെ ഏറ്റവും വലിയ ഒരു വൺ ഓഫ് ദ 2 ഡിസ്കവറീസ് ആണ് നമ്മുടെ. ദേവർ സോ. അപ്പം പത്മകുമാർ സാറിനെ ചോദിച്ചു നമുക്ക് എന്താ ചെയ്യുക, ബിക്കോസ് വി വർ ഷോർട്ട് ഓഫ് പീപ്പിൾ. അപ്പോൾ ഞാൻ പറഞ്ഞു വിഷ്ണുവും ഹരി അടുത്താണ്. ഹരി ഈസ് ഇൻ കോട്ടയം, വിഷ്ണു ഈസ് ഇൻ തിരുവല്ല. സോ ഐ ടോൾഡ് ലെറ്റ് us ഇൻവോൾവ് ദീസ് 2 പീപ്പിൾ. പിന്നെ അവർ രണ്ടുപേരുമാണ് ഇത് ടേക്ക് ഓവർ ചെയ്ത് ഇത്ര നന്നായിട്ട് ഓർഗനൈസ് ചെയ്തും സയൻറ്റിഫിക് പ്രോഗ്രാം ആൻഡ് എൻറ്റയർ ഓർഗനൈസേഷൻ വാസ് ഡൺ ബൈ ദീസ് 2 പീപ്പിൾ. I request all of you to have a loud round of applause for them. They have done so much hard work. Hats off to Vishnu and Hari. Hari did the science and Vishnu did the organization. And I am sure they are going to be great assets for IRA Kerala chapter in future. നിങ്ങൾക്ക് രണ്ടുപേർ ഔപചാരിക പേരിലാണെങ്കിലും ഈ വേദിയിലേക്ക് സ്വാഗതം ചെയ്യുന്നു. അതോടൊപ്പം തന്നെ ഡോക്ടർ വിനീത, ഡോക്ടർ യോഗേഷ്, they have come all the way from Bangalore, and Yogesh has come all the way from Bilaspur. So he has come from all the way. He has traveled 12-13 hours by flight and then by taxi. Madam has come from Bangalore. Thank you, ma'am. Welcome to the meeting. And without all these students and the medical representatives, it wouldn't have been possible to organize this meeting. So welcome all of you to the meeting. And I am sure next 2 days is going to be a academic extravaganza, and we will learn a lot of things. And there will be a lot of networking and meeting people and greeting. So expect for a very good meeting. Thank you.
Thank you, sir. Now I request Dr. Padmakumar sir for the presidential address.
എത്രയും ബഹുമാന്യനായ ഉദ്ഘാടകൻ, ആലപ്പുഴയുടെ പ്രിയങ്കരനായ ജനനേതാവ് ശ്രീ KC വേണുഗോപാൽ MP, ഈ വേദിയിൽ സന്നിഹിതരായിരിക്കുന്ന എൻ്റെ ബഹുമാന്യരായ സഹപ്രവർത്തകരെ, പ്രിയപ്പെട്ട കൊളീഗ്സ്, ടീച്ചേഴ്സ് ആൻഡ് മൈ ഡിയർ സ്റ്റുഡൻസ്, ഇന്ത്യൻ റൊമറ്റോളജി അസോസിയേഷൻ കേരള ഘടകവും ആലപ്പുഴയുമായിട്ടുള്ള അഭേദ്യമായിട്ടുള്ള ബന്ധത്തെക്കുറിച്ച് പ്രിയങ്കരനായ പത്മനാഭ ഷേണായി ഇവിടെ സൂചിപ്പിക്കുകയുണ്ടായി. അത് വളരെ ശരിയാണ്. റുമറ്റോളജി ഡിപ്പാർട്ട്മെൻറ്റ് പോലും ഇല്ലാത്ത ഒരു മെഡിക്കൽ കോളേജാണ് ആലപ്പുഴയിലുള്ളത്. അത്രമാത്രം എസ്റ്റാബ്ലിഷ്ഡ് ആയിട്ടുള്ള ഒരു സ്വകാര്യ ആശുപത്രി ഇവിടെയില്ല. വലിയ രീതിയിൽ ഡെവലപ്പ് ചെയ്തിട്ടുള്ള ഒരു റുമറ്റോളജി ഡിപ്പാർട്ട്മെൻറ്റുള്ള മറ്റ് ആശുപത്രികളും ഇവിടെയില്ല. എങ്കിൽ പോലും ഇന്ത്യൻ റുമറ്റോളജി അസോസിയേഷൻ്റെ കേരള ഘടകത്തിൻ്റെ രൂപീകരണം എന്ന് പറഞ്ഞത് ആലപ്പുഴയിലാണ് ഉണ്ടായത്. സോ ദി ബർത്ത് പ്ലേസ് ഓഫ് ഇന്ത്യൻ റുമറ്റോളജി അസോസിയേഷൻ കേരള ചാപ്റ്റർ വാസ് ഇൻ ആലപ്പി. അതുമാത്രമല്ല, 4 ആനുവൽ മീറ്റിങ്ങുകൾ കഴിഞ്ഞ 20 വർഷത്തിനുള്ളിൽ 4 ആനുവൽ മീറ്റിങ്ങുകൾ ആലപ്പുഴയിൽ വെച്ച് നടത്തുവാൻ കേരള ചാപ്റ്ററിന് സാധിക്കുകയുണ്ടായി. അപ്പോൾ എന്തുകൊണ്ടോ ആലപ്പുഴയും ഇന്ത്യൻ റുമറ്റോളജി അസോസിയേഷനുമായി ഒരു അഭേദ്യമായിട്ടുള്ള ഒരു ബന്ധമുണ്ട് എന്നുള്ളത് വളരെ കൗതുകകരമായിട്ട് തോന്നുന്നു. ഇവിടെ പത്മനാഭ സൂചിപ്പിക്കുകയുണ്ടായി, റുമറ്റോളജി എന്ന് പറയുന്ന നമ്മുടെ ചികിത്സാ വിഭാഗത്തിൽ വലിയ മാറ്റങ്ങളുണ്ടായിട്ടുണ്ട്. അതിൻ്റെ പ്രയോജനം സാധാരണക്കാരായിട്ടുള്ള ജനങ്ങൾക്ക് ലഭിക്കേണ്ടതുണ്ട്. അതിന് ബഹുമാന്യനായ ശ്രീ KC വേണുഗോപാൽ, അദ്ദേഹത്തെ പോലെയുള്ള ജനപ്രിയരായിട്ടുള്ള നേതാക്കന്മാർ, ജനപ്രിയർ മാത്രമല്ല, അവർ വളരെയേറെ ധിഷണാശാലികളാണ്. വളരെയേറെ ഇക്കാര്യത്തിലൊക്കെ ഹാർഡ് വർക്ക് ചെയ്യുന്ന ധിഷണാശാലികളായിട്ടുള്ള നേതാക്കന്മാരാണ്. അങ്ങനെയുള്ളവരുടെ ശ്രദ്ധ ഇങ്ങനെയുള്ള കാര്യങ്ങളിൽ പതിക്കേണ്ടതുണ്ട്. ക്യാൻസറും അതല്ലെങ്കിൽ ഡയബറ്റിസും മാത്രമല്ല മാരകമായിട്ടുള്ള രോഗങ്ങൾ. ഇതുപോലെയുള്ള റെയർ ഡിസീസസ് ആർ ദെയർ. അങ്ങനെയുള്ള രോഗികൾക്കും ഒരിക്കൽ ഈ രോഗം വന്നു കഴിഞ്ഞാൽ ആജീവനാന്ത ചികിത്സയാണ് വേണ്ടത്. ഇപ്പോൾ SLE പോലെയുള്ള രോഗങ്ങളെക്കുറിച്ച് നമുക്കറിയാം. ക്യാൻസറിനെക്കുറിച്ച് നമ്മൾ ധാരാളം സംസാരിക്കുന്നു, ക്യാൻസറിനെക്കുറിച്ചുള്ള അവയർനെസ് നടത്തുന്നു, ക്യാൻസർ രോഗികൾക്ക് എല്ലാ സപ്പോർട്ടും കൊടുക്കരുതെന്നല്ല ഞാൻ പറയുന്നത്. ട്യൂബർക്കുലോസിസ് രോഗികൾക്ക് വേണ്ടി നാഷണൽ ട്യൂബർക്കുലോസിസ് പ്രോഗ്രാമുകൾ നടക്കുന്നു, മലേറിയ ഇറാഡിക്കേഷൻ പ്രോഗ്രാം നടക്കുന്നു. പക്ഷേ നിർഭാഗ്യവശാൽ ഇതുപോലെയുള്ള റെയർ ഡിസീസസിനെ കുറിച്ചുള്ള കൃത്യമായിട്ടുള്ള ഒരു ഔട്ട്ലുക്ക്, ഒരു വീക്ഷണം, ദീർഘവീക്ഷണം സർക്കാരിനില്ല, ഗവൺമെൻറ്റിനില്ല എന്നുള്ളത് ഒരു വലിയ ന്യൂനതയാണ്. ഇതുപോലെയുള്ള ജനപ്രിയരായിട്ടുള്ള നേതാക്കൾ ഇങ്ങനെയുള്ള കാര്യങ്ങളിൽ ശ്രദ്ധിക്കണമെന്ന് മാത്രം ഈ അവസരത്തിൽ സൂചിപ്പിച്ചുകൊണ്ട് ഒരു കാര്യം കൂടി പറഞ്ഞുകൊള്ളട്ടെ. കേരളത്തിൻ്റെ, ഇപ്പോൾ ഞാൻ ബഹുമാനപ്പെട്ട MP-യുമായിട്ട് അത് സംസാരിക്കുകയുണ്ടായി, കേരളത്തിൻ്റെ ഒരു വലിയ പാരഡോക്സ് ഉണ്ട്. നമുക്ക് ഏറ്റവും കൂടുതൽ ലിറ്ററസിയുള്ള സ്റ്റേറ്റാണ് കേരളം എന്ന് പറയുന്നത്. പക്ഷേ ഇന്ത്യയിൽ ഏത് പകർച്ചവ്യാധി ആദ്യം റിപ്പോർട്ട് ചെയ്യുന്നതും കേരളത്തിൽ തന്നെയാണ്. വൈ ദിസ് പാരഡോക്സ്? അതും നമ്മൾ ചിന്തിക്കേണ്ടതാണ്. കൂടാതെ മെൻ്റൽ ഹെൽത്ത് ഈസ് ഓൾസോ വെരി ലെസ് ഇൻ കേരള. ഏറ്റവും കൂടുതൽ സൂയിസൈഡ് നടക്കുന്ന ഒരു സ്റ്റേറ്റും കേരളം തന്നെയാണ്. സോ വൺ സൈഡ് ദർ ഇസ് എ ഹൈ ലിറ്ററസി, ഓൺ ദി അതർ സൈഡ് ഈ പറയുന്ന ഹെൽത്ത് ഇൻഡിസസ് ആർ വെരി ലോ, ഇൻക്ലൂഡിങ് എപ്പിഡമിക്സ്. അപ്പോൾ തുടങ്ങിയ കാര്യങ്ങളെക്കുറിച്ച് നമ്മൾ തീർച്ചയായിട്ടും ചർച്ച ചെയ്യേണ്ടതുണ്ട്. ഏതായാലും റുമറ്റോളജി വിഭാഗത്തിൻ്റെ കേരള ചാപ്റ്ററിൻ്റെ ഈ മീറ്റിംഗ് ഇവിടെ നടക്കുമ്പോൾ നിങ്ങളെല്ലാവരെയും ഈ ചടങ്ങിലേക്ക് സ്വാഗതം ചെയ്യുന്നതിൽ എനിക്ക് അതിയായ സന്തോഷമുണ്ട്. ബഹുമാന്യനായ MP-ക്ക് വളരെ സമയക്കുറവുണ്ട്. അദ്ദേഹത്തിൻ്റെ സമയക്കുറവ് കൂടി പരിഗണിച്ച് ഞാൻ എൻ്റെ സംഭാഷണം അവസാനിപ്പിക്കുന്നു. എല്ലാവരെയും ഈ മീറ്റിങ്ങിലേക്ക് ഒരിക്കൽ കൂടി സ്വാഗതം ചെയ്യുന്നു. നന്ദി, നമസ്കാരം.
Thank you, sir. Now it is my honor and privilege to request our chief guest of the day, Shri KC Venugopal sir, to please light the lamp and inaugurate Keracon 2024.
പ്രിയപ്പെട്ട ഡോക്ടർ പത്മകുമാർ, ഡോക്ടർ ഷെണായ്, മറ്റു വിശിഷ്ട അതിഥികളെ, സഹോദരി സഹോദരന്മാരെ, റൂമറ്റോളജി അസോസിയേഷൻ്റെ കേരള ചാപ്റ്ററിൻ്റെ ഒരു ആനുവൽ കോൺഫറൻസ് അതിൻ്റെ ഭാഗമാകാൻ എനിക്ക് അവസരം തന്നതിന് സംഘാടകരോട്, ഡോക്ടർ പത്മകുമാറിനോടും ഷെണായിയോടും ഒക്കെ ഞാൻ ആദ്യമായി നന്ദി രേഖപ്പെടുത്തുകയാണ്. നേരത്തെ സൂചിപ്പിച്ചതുപോലെ ആർത്രൈറ്റിക്സും റൂമറ്റോളജിയുടെ വിവിധങ്ങളായിട്ടുള്ള രൂപഭാവങ്ങളും കൊണ്ട് നമ്മുടെ നാട് പ്രയാസം അനുഭവിക്കുന്ന ഒരുപാട് പേരുണ്ട്, നമുക്കെല്ലാവർക്കും അറിയാം. ഈ ശാഖയുടെ വികസനം, ഇതിൻ്റെ ഗവേഷണം, ഇതുമായി ബന്ധപ്പെട്ടുള്ള സംവാദങ്ങൾ ഈ ഡിപ്പാർട്ട്മെൻറ്റിനെ ശക്തിപ്പെടുത്തുക മാത്രമല്ല, അത് താഴെത്തട്ടിലേക്ക് ഇതുമൂലം പ്രയാസം അനുഭവിക്കുന്ന ജനങ്ങളിലേക്ക് സഹായം എത്തിക്കാനും ഈ കോൺഫറൻസ് സഹായകരമാകും എന്ന് പ്രത്യാശിക്കുകയും ചെയ്യുകയാണ്. നമ്മുടെ ഇന്ന് ആരോഗ്യമേഖലയിൽ നേരത്തെ പത്മകുമാർ സൂചിപ്പിച്ചത് ഞാനും ആലോചിക്കുകയായിരുന്നു. ചിക്കൻ ഗുനിയ വന്നൊരു കാലത്ത് എനിക്ക് ഓർമ്മയുണ്ട്. ഞാനന്ന് MLA ആണ്, ആലപ്പുഴ MLA. അന്ന് എൻ്റെ ഒരു അടിയന്തര പ്രമേയം ഉണ്ടായിരുന്നു കേരള നിയമസഭയിൽ, ആലപ്പുഴയെ ഗ്രസിച്ചിരിക്കുന്ന ചിക്കൻ ഗുനിയ രോഗം. അതിൻ്റെ ഒരു ആഫ്റ്റർ എഫക്റ്റായിട്ട് പിന്നീട് പലരും പറഞ്ഞത് മുട്ടുവേദന, സന്ധിവേദന, ഇതുമായി ബന്ധപ്പെട്ടുള്ള ആർത്രൈറ്റിസ് റിലേറ്റഡ് ആയിട്ടുള്ള ഒരുപാട് ഡിസീസായിരുന്നു. അന്ന് നമ്മൾ മെഡിക്കൽ കോളേജിനോട് ആവശ്യപ്പെട്ടു, നമ്മുടെ മെഡിക്കൽ കോളേജിനെ സംബന്ധിച്ച് എന്തെങ്കിലും ഗവേഷണം ഉണ്ടായിട്ടുണ്ടോ? ഇല്ല. രോഗചികിത്സയല്ലാതെ, രോഗം വരുമ്പോഴുള്ള ചികിത്സയല്ലാതെ ഈ രോഗങ്ങളെക്കുറിച്ചുള്ള ഫലപ്രദമായിട്ടുള്ള ഗവേഷണങ്ങൾ, നേരത്തെ സൂചിപ്പിച്ചതുപോലെ ലിറ്ററസിയിൽ ഏറ്റവും മുന്നിലായ കേരളത്തിൻ്റെ സംഭാവന എത്രത്തോളം ഉണ്ട് എന്നുള്ളത് വി നീഡ് ടു തിങ്ക് അബൌട്ട് ഇറ്റ്. ഇപ്പോൾ പോസ്റ്റ് കോവിഡ് റിലേറ്റഡ് ആയിട്ടുള്ള ഒരുപാട് അസുഖങ്ങൾ പലരും റിപ്പോർട്ട് ചെയ്യുന്നു. വളരെ ചെറുപ്പക്കാരായിട്ടുള്ള ആളുകൾ ഹാർട്ട് അറ്റാക്ക് മൂലം മരിക്കുന്നു. ഒരു പ്രതീക്ഷയില്ലാത്ത രോഗങ്ങൾ പലപ്പോഴും വന്നുകൊണ്ടിരിക്കുന്നു. ഞങ്ങൾ പൊതുപ്രവർത്തകരായ ദിവസേന നൂറുകണക്കിന് ഇങ്ങനെ മരണ വീടുകളും മരണ വാർത്തകളും ഒക്കെ കേട്ടുകൊണ്ടിരിക്കുന്നവരായതുകൊണ്ട് പോസ്റ്റ് കോവിഡ് പല ഡോക്ടർമാരോടും ചോദിക്കുമ്പോൾ അവർക്ക് ആക്ച്വലി എന്താണ് ഇതിൻ്റെ റീസൺ എന്നാർക്കും പറയാൻ പറ്റുന്നില്ല. ഞാൻ ചോദിക്കുന്നത്, കേരളം നമ്മുടെ മുന്നിലാണ്. വേൾഡ് ഹെൽത്ത് ഓർഗനൈസേഷൻ്റെ സ്റ്റാൻഡേർഡിൽ പോലും ആരോഗ്യ മേഖലയിൽ നമ്മൾ വളരെ മുന്നിലാണ്. എഡ്യൂക്കേഷൻ സെക്ടറിൽ നമ്മൾ പറയുന്നത് പോലെ ഇത് രണ്ട് വൈരുദ്ധ്യങ്ങൾ എടുക്കുമ്പോഴും റിസൾട്ടിൻ്റെ കാര്യത്തിൽ അത് ഞാൻ ഡോക്ടർമാരെ കുറ്റപ്പെടുത്തുകയല്ല. ഡോക്ടർമാരല്ലല്ലോ അത് ചെയ്യേണ്ടത്. ഞങ്ങൾ ഭരണാധികാരികളാണ് ഇതിനൊരു ഡയറക്ഷൻ കൊടുക്കേണ്ടത്, ദിശാബോധം കൊടുക്കേണ്ടത്. നമ്മുടെ ഡോക്ടർ സമൂഹത്തിന് പലപ്പോഴും സമൂഹം കൊടുക്കുന്നത് നെഗറ്റിവിറ്റി മാത്രമാണ്. ഇപ്പം RG കാറിലുണ്ടായിട്ടുള്ള ഏറ്റവും ഒടുവിലെ കൽക്കത്ത മെഡിക്കൽ കോളേജിലെ സംഭവം പോലും ഇന്ത്യയിലെ മൊത്തം കണ്ണുറപ്പിച്ച സംഭവമായിട്ട് മാറിയത്. ആരോഗ്യ മേഖലയിൽ മറ്റെല്ലാ മേഖലകളിലും പോലെ അനഭിലഷണീയമായ പ്രവണതകൾ ഉണ്ടായിരിക്കാം. പക്ഷേ ആര് പ്രൊട്ടക്റ്റ് ചെയ്യുന്നു ഈ മേഖലയിൽ പ്രവർത്തിക്കുന്നവരെ? ഈ മേഖലയിൽ ആഴത്തിൽ റിസർച്ച് ചെയ്യാൻ ആഗ്രഹിക്കുന്നവരെ ആര് സപ്പോർട്ട് ചെയ്യുന്നു? സിൻസിയറായി ജോലി ചെയ്യുന്നവരെ അവർക്ക് എന്തുമാത്രം പ്രചോദനം ലഭിക്കുന്നുണ്ട്? അത് റൂമറ്റോളജിക്കാർക്കും അങ്ങനെ. ഇപ്പം നേരത്തെ ഇവിടെ സൂചിപ്പിക്കേണ്ടായി, ആലപ്പുഴ മെഡിക്കൽ കോളേജിൽ ഇതിൻ്റെ ഒരു യൂണിറ്റ് പോലും ഇല്ല. നിങ്ങളെന്നാലും ആലപ്പുഴയിൽ ഈ പ്രസ്ഥാനം രൂപം കൊണ്ടു, ഷെണായും പത്മകുമാറൊക്കെ കൂടി. നമ്മൾ ഗൗരവമായിട്ട് ചിന്തിക്കേണ്ട കാര്യം, നേരത്തെ ഇവിടെ സൂചിപ്പിച്ചു, ഏത് രോഗത്തിൻ്റെയും ഇമ്മീഡിയറ്റ് സോഫ്റ്റ് ടാർഗറ്റ് കേരളമാണിപ്പോൾ. കേരളമാണ് എല്ലാ തലത്തിൽ നോക്കിയാലും മറ്റേത് സംസ്ഥാനങ്ങളെക്കാളും സ്റ്റാൻഡേർഡിൽ മുന്നിൽ. നിങ്ങൾ എന്നോട് ക്ഷമിക്കണം, നിങ്ങൾക്ക് അതിനകത്ത് വിരോധമുണ്ടെങ്കിൽ നിങ്ങൾക്ക് പറയാം. പക്ഷേ കേരളത്തിലെ ആരോഗ്യ മേഖല സർക്കാർ ആശുപത്രി പോലും പ്രവർത്തിക്കുന്നത് സ്വകാര്യ മേഖലയ്ക്ക് വേണ്ടിയാണോ എന്ന് സംശയിക്കുന്ന ഒരാളാണ് ഞാൻ. കേരളത്തിൽ ഫ്ലറിഷ് ചെയ്യുന്ന ഏക ഇൻഡസ്ട്രി പ്രൈവറ്റ് ഹോസ്പിറ്റലല്ലേ? സർക്കാർ മെഡിക്കൽ കോളേജുകൾ നമുക്കുണ്ട്. സർക്കാർ മെഡിക്കൽ കോളേജിൽ ഒരു സൂപ്പർ സ്പെഷ്യാലിറ്റി സൗകര്യങ്ങളിൽ ഫൈനാലിറ്റി കൊടുക്കും എന്ന് പറയുന്ന സർക്കാർ മെഡിക്കൽ കോളേജ് എന്ന് പറയുന്നൊരു വിശ്വാസ്യത നേടിയെടുക്കാൻ നമുക്കാവുന്നുണ്ടോ? ഇപ്പോൾ ആലപ്പുഴയിൽ ആർക്ക് അസുഖം വന്നാൽ നേരെ എടുത്തു കൊണ്ടുപോവാണ് എറണാകുളത്തേക്ക്. 2, 3, 4, 5 ആശുപത്രികളുണ്ട്. അവരുടെ യഥാർത്ഥ കാര്യങ്ങളൊക്കെ നമ്മൾ പറഞ്ഞാൽ നിങ്ങൾക്കത് ഇഷ്ടപ്പെടുന്നില്ല, എനിക്കറിയാം. പൊതുപ്രവർത്തകർ എന്ന നിലയിൽ ഏറ്റവും നല്ല ഹ്യൂമൻ റിസോഴ്സസ് എവിടെയാണുള്ളത്? ഗവൺമെൻറ് മെഡിക്കൽ കോളേജിൽ, ഗവൺമെൻറ് കോളേജുകളിൽ, ഗവൺമെൻറ് ആശുപത്രികളിൽ. ഈ ഏറ്റവും നല്ല ഹ്യൂമൻ എച്ച് ആറിനെ ഫലപ്രദമായി വിനിയോഗിക്കപ്പെടാത്തത് കൊണ്ട് നെഗറ്റിവിറ്റി മുഴുവൻ അവരിലേക്ക് വരികയും ഇതിൻ്റെ മൊത്തം ബെനിഫിറ്റ് കേരളത്തിലെ പ്രൈവറ്റ് ആരോഗ്യ മേഖല കൈയെടുക്കുകയും ചെയ്യുന്നൊരു അന്തരീക്ഷമാണ് ഇന്ന് കേരളത്തിലുള്ളത്. അറിഞ്ഞോ അറിയാതെയോ നമ്മളെല്ലാവരും അതിൻ്റെ ഭാഗവാക്കാകുകയും ചെയ്യുന്നുണ്ട്. ഇവിടെ തൊലിപ്പുറത്തിരുന്ന് ചികിത്സ നടത്തിയിട്ട് യാതൊരു കാര്യവുമില്ല. ഞാനിപ്പം ആരെയും വ്യക്തിപരമായിട്ട് ഏറ്റെടുത്ത് കുറ്റപ്പെടുത്തുകയല്ല. നമ്മൾ ആലപ്പുഴ മെഡിക്കൽ കോളേജിന് സൂപ്പർ സ്പെഷ്യാലിറ്റി ഹോസ്പിറ്റലിൽ സൗകര്യം കൊണ്ടുവന്നു. ഇന്ത്യൻ ഗവൺമെൻറ്റിൻ്റെ ഏറ്റവും വലിയ പ്രസ്റ്റീജിയസ് പ്രോഗ്രാമായ PMSSYയിൽ പെടുത്തിയിട്ടാണ് നമ്മളന്ന് കൊണ്ടുവന്നത്. 2014 അനുവദിച്ചത് ഇന്ന് പോലും ആരംഭിക്കാൻ കഴിഞ്ഞിട്ടില്ല പൂർണ്ണാർത്ഥത്തിൽ. 10 വർഷം അതിൻ്റെ കൺസ്ട്രക്ഷനുമായി ബന്ധപ്പെട്ടുള്ള പിന്നെ ഡോക്ടേഴ്സ് അപ്പോയിൻമെൻറ്റ്സ്, അതിൻ്റെ ലബോറട്ടറി എക്വിപ്മെൻറ്റ്സ്, സൗകര്യങ്ങൾ ഡിസ്കസ് ചെയ്യുകയാണ്. ഇപ്പോൾ ഇന്ന് എന്നോട് കലക്ടർ പറഞ്ഞത് പഴയ മെഡിക്കൽ കോളേജും പുതിയ സൂപ്പർ സ്പെഷ്യാലിറ്റി തമ്മിൽ കണക്ഷനില്ല. 10 കൊല്ലം കഴിഞ്ഞിട്ടാണ് നമ്മൾ ആലോചിക്കുന്നത്. അപ്പോൾ ഞാൻ പറഞ്ഞു വരുന്നത്, അത് ഭരണം നടത്തുന്നവർ, ഞാനായാലും വേറെ ആളായാലും, അതിപ്പോൾ ഏതെങ്കിലും പൊളിറ്റിക്കൽ പാർട്ടി, ഏതെങ്കിലും ഒരു പ്രത്യേക പൊളിറ്റിക്കൽ പാർട്ടിയോ ഏതെങ്കിലും ഭരിക്കുന്ന ആളെ കുറ്റപ്പെടുത്തി പറയല്ല. ആരോഗ്യ മേഖലയിൽ ദീർഘവീക്ഷണത്തോടെയുള്ള ഇൻസൈറ്റ് പ്രദാനം ചെയ്യുന്ന ഡിസിഷൻ മേക്കിംഗ്, അതനുസരിച്ചുള്ള ആക്ഷൻ ടേക്കണോ ഉണ്ടാകുന്നില്ലെങ്കിൽ നമ്മളീ പറയുന്ന കൊട്ടിഘോഷിക്കപ്പെടുന്ന കേരളത്തിൻ്റെ വലിയ ആരോഗ്യ സംഭാവനകൾ അത് ഫലത്തിലേക്ക് വരില്ല എന്നുള്ളതാണ് വർത്തമാന കേരളം നേരിട്ടുകൊണ്ടിരിക്കുന്ന ഏറ്റവും വലിയ ഉദാഹരണം. അതിന് മാറ്റം ഉണ്ടാകണമെങ്കിൽ ഇതുപോലുള്ള ഡോക്ടർമാരുടെ കൂടിച്ചേരലുകളിലൂടെ ഉണ്ടാകേണ്ട ഒരു നല്ല ഡിസ്കഷൻസ് ഇതിനെ പ്രോത്സാഹിപ്പിക്കപ്പെടണം. എല്ലാ വർഷവും കേരളത്തിലെ ഡോക്ടർമാർ ഏറ്റവും കഴിവുള്ളവരുണ്ട്, ഏറ്റവും പ്രാമാണികരായിട്ടുള്ള ആളുകളുണ്ട്. ഇന്ത്യയിലെ ഏത് ഡോക്ടർമാരെയും വെല്ലുവിളിക്കാൻ കഴിയുന്ന അത്രയും നല്ല കേപ്പബിളായിട്ടുള്ള ആളുകളുണ്ട്. അവരുടെ ശേഷി പരിപൂർണമായി വിനിയോഗിക്കപ്പെടാനും അത് വിനിയോഗിക്കപ്പെടുന്നതനുസരിച്ച് അത് ആക്ഷനിലേക്കും പ്രോഗ്രാമിലേക്കും മാറ്റിയെടുക്കാനും വേണ്ടിയിട്ടുള്ള ഒരു ചാനൽ പ്രവർത്തിക്കുന്നില്ലെങ്കിൽ ഈ പറയുന്ന ഗുണപരമായ മാറ്റങ്ങളിലേക്ക് നമുക്ക് പോകാൻ കഴിയില്ല. അത് എടുക്കേണ്ടത് നിങ്ങളല്ല, സർക്കാരാണ് എടുക്കേണ്ടത്. സർക്കാർ അതുകൊണ്ട് ഏതെങ്കിലും ഇപ്പം നമ്മളിപ്പോൾ മിക്കവാറും സമയം ചിലവഴിക്കുന്നത്, കഴിഞ്ഞ ദിവസം ഞാൻ കണ്ടപ്പോൾ ഒരു 1.5-2 മണിക്കൂർ നമ്മുടെ മാധ്യമങ്ങളിലെ ചർച്ച തിരുവനന്തപുരത്തെ WNC ഹോസ്പിറ്റലിൽ, നമ്മുടെ ഉത്രാടം എന്നുള്ള ഹോസ്പിറ്റലിൽ ജനറേറ്റർ ഇല്ല. ഒന്ന് ആലോചിച്ച് നോക്കിയേ. ഒരു ജനറേറ്റർ ഇല്ലാത്ത ചർച്ചയാണ് കേരളത്തിലെ ആരോഗ്യ വകുപ്പിൻ്റെ അത് മാധ്യമങ്ങളെ സംബന്ധിച്ചിടത്തോളം അത് പ്രധാനപ്പെട്ട വാർത്തയാണ്. വെച്ചാൽ ഒരു ഏറ്റവും പ്രധാനപ്പെട്ട ഒരു സർക്കാരിൻ്റെ സെക്രട്ടേറിയറ്റിൻ്റെ കണ്ണ് ഒരു മുന്നോട്ട് നോക്കാൻ വന്ന ഹോസ്പിറ്റലിലെ സ്ഥിതിയാണ്. അപ്പോൾ ഇതിന് മാറ്റം ഉണ്ടാകണം. ഞാൻ നേരത്തെ സൂചിപ്പിച്ച പോലെ റുമറ്റോളജി അസോസിയേഷൻ്റെ വ്യാപ്തി എത്രത്തോളം ഉണ്ടെന്ന് എനിക്കറിയില്ല. പക്ഷേ ഇതെല്ലാം പൊതുജനാരോഗ്യത്തിൻ്റെ ഭാഗമാണല്ലോ, പബ്ലിക് ഹെൽത്തിൻ്റെ ഭാഗമാണല്ലോ. വി ആർ ഡിസ്കസിങ് അബൌട്ട് ദ പബ്ലിക് ഹെൽത്ത്. അപ്പോൾ ഇത് ശക്തിപ്പെടുത്താൻ ഡോക്ടർമാർ, എനിക്ക് പറയാനുള്ള, ചികിത്സാ മുറികളിൽ നിന്നും പുറത്തോട്ടിറങ്ങണം. നിങ്ങളുടെ ലോകം പ്രത്യേക ലോകത്താണ്. നിങ്ങൾ ഭൂരിഭാഗം ആളുകളും, കുറച്ച് ആളുകൾ പത്മവർണ്ണ പോലെ ആളുകൾ ഇറങ്ങുന്നുണ്ട്, എഴുതുന്നുണ്ട്, പറയുന്നുണ്ട്. പക്ഷെ മറ്റു പലരും അവരവരുടെ ജോലി ചെയ്തു പോകും. ആ ജോലി തന്നെ ചെയ്യുമ്പം പൂർണ്ണ സംരക്ഷണം ഉണ്ടോ ഇല്ലയോ അല്ലെ സെക്യൂരിറ്റി ആശങ്കകളാണ്. അതിനപ്പുറത്ത് നിങ്ങളുടെ ലോകത്തു നിന്ന് ഇറങ്ങി വന്ന് നിങ്ങൾക്ക് ചെയ്യാവുന്ന കോൺട്രിബ്യൂഷൻ സൊസൈറ്റിക്ക് വേണ്ടി, നിങ്ങളുടെ രോഗിക്കപ്പുറം ഒരു ലോകമുണ്ട് പുറത്ത്. ആ ലോകത്തിന് വേണ്ടി ഹൗ കാൻ ഐ കോൺട്രിബ്യൂട്ട് എന്നുള്ളൊരു ചിന്തയും നിങ്ങളുടെ ചിന്തകളെ പ്രോത്സാഹിപ്പിക്കാനുള്ള ഒരു സർക്കാർ സംവിധാനവും ഉണ്ടായാൽ മാത്രമേ ഈ കൂടിച്ചേരലുകൾക്ക് റിസൾട്ടായിട്ടുള്ള പ്രശ്നങ്ങൾ ഉണ്ടാകുമെന്നുള്ള എൻ്റെ ചെറിയ ചിന്തകൾ പങ്കുവെച്ചുകൊണ്ട് ഈ സമ്മേളനം ഉദ്ഘാടനം ചെയ്യുന്നു. നമസ്കാരം. ജയ് ഹിന്ദ്.
Thank you, sir, for those enlightening words.